Look. That clicker.
Or I'll break every one of your fingers one by one. Just snap it. It took a minute to get it to work the other day. Which is the same one? Those no, because they didn't get saved to the cloud. So it'll save everything. But it keeps people from not logging in. This one will be. But you can go back to earlier and listen to it. If they get saved to the cloud. So the two that is not. This one will. So if we're not able to be here, then you just need to text Sherry the code. Yep. And if for some reason
I give them a break.
No, I'm not gonna do it. I'm not gonna do it. No way I'm gonna watch all night. Let him know. He will save it. We just don't save every one of them.
You ready? All right. All right, we'll go ahead and get started for the morning. Yesterday, you spent pretty much doing airway and respiratory, and we used some slides that I had gotten from Roger that he loaned us for class, luckily. And today we got lucky enough that he's off work. Normally a flight paramedic at Baptist, and talked him into coming and teaching some cardiology for you this morning and this afternoon. I think you'll enjoy the presentation. It's one of those, when I look at something and go, what the crap is this? I usually send it to him, and then he sends me crap, and I go, I don't have a clue what I'm looking at, so you're going to have to explain it. So I think you get a lot out of it. It'll start out pretty slow, very basic, basic interpretation, reviewing basic rhythms, that kind of thing, and then advance further. We were walking down the hall, like I told you yesterday, November, EMS World. He had an article in, and next month the second one's coming out. So his article actually was in the magazine out front there on the cocaine effects. So let Roger start reviewing some cardiology with you.
My name's Roger Lale. I've been a paramedic for about 15 years. I've been with block service for around 10 now. I fly for Baptist Air Care. I work in ground truck as well. So I do a lot of EKG research, and I just help Dr. Stapire complete we've done a research project on STEMI, how people are treated when they're brought to STEMI, are they given any feedback, or, what's your location to a PCI center, and I think there was, Cleveland actually helped us do that. But I teach a lot of classes in EKG interpretation. I've actually wrote a book and working on getting it published, me and Corey are, so I like to start out with the basic stuff. We're going to go over lead 2 monitoring. We're going to look at different stuff we see every day. But just keep in mind, all we're seeing with lead 2, you'll see all lead 2 up here. We're just looking from here to here. The right arm, the left leg, it's looking at lead 2, okay? We're going to get several different looks, but we're going to start with what we'll basically see whenever we run a lead 2 strip on our monitors. Where do limb leads go? That's right. We'll talk about axis here in a little bit, but if we don't put them in the proper location, then we're going to get our readings can be skewed. We might miss something very important especially when it comes to a block. Okay. So here's our components of our EKG and lead 2. So our P wave is going to be our first positive deflection before the QRS complex. Q waves, it's the first negative deflection before any positive deflection, and it's an abnormal finding in all normal 12 leads. We're going to talk about the difference between a physiologic and a pathological Q wave here in a little bit. R wave is the first positive deflection of the QRS. We're going to see different R wave patterns, S wave, J point, and a QT interval. These are normal variables. Our rate's going to be 6 to 100. Normal PDR intervals, 120 to 200 milliseconds. QRS should be 180 to 120 milliseconds in duration, and a QT interval greater than 460 will be a prolonged QT interval for us. Can y'all see that okay? It's not blurry. Okay. What's this rhythm? Unless stable rhythm on demand. Right. We can always start back to here, right? Shock it till we figure it out. The biggest thing is, especially if you're confirming in 2 leads, you have a person that's, I don't know y'all's protocol down here, but before we confirm a death, up there, you have to have 2 leads, confirm the system. Make sure your leads are on. Sinus rhythm, 60 to 100. We got a P wave for QRS complex and a T wave. It's regular, same heart to heart interval. Our P waves are normal, upright. Somebody be having this ST elevation in mind, have a perfect heart rate of 70 and sinus rhythm. Like I said, we're only looking at lead 2. There's several other locations on the heart we can be having a big STEMI and perfect rhythm. Is y'all's protocols down here, are you required to do a 12 lead before you give nitroglycerin?
Yes.
That's good. Is this an abnormal finding? Usually for anybody? Depends on the patient, exactly. You can have sinus bradycardia in a 6-year-old is a problem, right? The sinus bradycardia, an issue for a 24-year-old that runs 7-8 miles every day, probably is a perfect picture of health. They're going to have a low resting heart rate. We need to, know our rhythms, but know what fits where. Okay. Sinus tach. How do we usually treat this? If it's 140 and below.
Figure out one.
Wow. Okay. Is it exertion? Is it fever? Are they compensating for something? Is everybody, whenever we have somebody in sinus tachycardia, depending on our patient, we're going to treat our underlying cause, right? The first thing you're going to do if they're hypoxic, their heart rate's going up. If they're, been traumatized, whatever, their heart rate's going to go up. So we need to know why. Okay. How about this one? What's this one? When we see something like this, what are we usually? Say it's a trauma patient. What are we thinking about? They take a deep breath.
Pneumothorax.
Pneumothorax. Anything else?
Left ears.
Okay. What else? It's in the chest.
Tamponade?
Tamponade. Exactly.
Hmm.
So here's a big sign for cardiac tamponade. Of course, we're doing an assessment on our patient, but this particular EKG rhythm is something that can kind of key us into something else, or just something that you'll see with it. Well, what's this one? Are we going to treat it? Depends. Right. We always treat our patient, not to monitor, right? Okay. The only rhythm we are going to treat regardless is VTAC. That's the only rhythm we have to treat. Stable, unstable, or whatever, because VTAC will degrade to defib systole. When our patients, what's y'all's definition of best VT? 150 and above, 160 and above, 170 and above?
180.
180. Okay. For me, usually, if I'm looking at a heart rate above 180, 200, I'm thinking it's probably more AFib RVR. That's just me personally. 12 lead. If they're stable enough that I can run a 12 lead, I'm going to run a 12 lead on them. If they're not, we'll spark them. We'll figure it out in a minute. Oops. So if it's too fast, we're going to try to slow it down. We're always going to look at our H's and T's. Most of the time, you're going to be able to figure out, is it a toxin that's causing it? Is it some sort of acidosis causing it? Are they septic? They're compensating? Trauma? Something is causing them to be out of kilter there. PVCs. Do we treat PVCs?
Symptomatic.
Do we give pharmacological intervention for PVCs?
No.
Right. Okay. We're going to figure out what's going on. Okay. 3 PVCs in a row is supposed to be VTAC, right? Or a run of VTAC. All right. So we have different kinds of PVCs or different interpretations of PVCs. A PVC that does not disturb the underlying rhythm at all. So the R to R intervals are normal, doesn't disturb the rhythm. Most of us have a PVC if we drink cup of coffee, we'll see a PVC occasionally. It doesn't bother us. We don't really feel it. Those are interpolated. Unifocals are coming from the same area. It could be benign. People live with them every day. It doesn't affect them. And then other people can feel it when they're having PVCs. They can feel it in their chest. They can feel palpitations, dyspnea. Those can tend to be a problem. It is ventricular irritability. Okay? This one's more regular. I see bigeminy, trigeminy a lot. You know, you ask them, "You feeling okay?" Yeah. That'd be something that they live with, especially if they have a history of, you know, MIs, things like that. They can have some irritability. This one gets to be a little bit more concerning when they're coming from different locations or different areas in the heart. Okay? Usually, well, we're always going to run a 12 lead, especially when we see this, but this is usually one that'll get us more concerned whenever they're, you know, coming from different areas. Couplets, you know, 3 in a row is supposed to be a short run to be tacked. We're going to run a 12 lead on them and see if we're going to need to be thinking about an antiarrhythmic or something else. I'm not going to give any antiarrhythmic for just PVCs. I'm going to try to find the underlying cause. Once they go into sustained VTAC, we're either going to bolus them or spark them. PACs, this is really, we see it a lot, and we see there's an irregularity in the rhythm. I've seen a physician call PACs, he called it AFib. I was like, perfectly regular. He's like, no, it's irregularity. I said, no. One of those doesn't even hurt the underlying rhythm. And there's PJCs, and you don't usually see premature junctional contractions. That's pretty rare. How about this one? We're going to do something to this one, right? It's got a pulse. What we're going to do? Cardiovert. What if they got a GCS 15? Skin's warm, pink, and dry. Blood pressure's 120 over 80.
Yeah, we got it.
You got it wrong? Or lidocaine. I'm not a big fan of that. No. Just don't like it. So I like the choices in ACOS. Lidocaine is my preference. I just had a lot better success with it. I'll show you guys a 12 lead here in a little bit. We'll talk about axis. I showed you a little bit ago. It's really bizarre, but this patient's in VTAC. So to be VTAC, it's got to be a wide complex, right? Okay. What are we going to do if we cardiovert this? Say it's running at 200. As soon as we cardiovert, they go into a narrow complex at that rate. What do we do then?
At the same rate?
Mm-hmm. So this rate right here is 210. Okay. We cardiovert them at 120 joules. And they go into a narrow complex tachycardia.
You just switch your medicine or cardiovert your different joule setting. Because you're now going from a wide complex to a narrow complex.
Exactly. I've seen it happen once. Still treating a tachyarrhythmia. Sometimes you just have to adapt to a change. What about this one?
Mag.
Mag. Or this one is the only one we're going to defibrillate this. It gets a DC counter shock, 200 joules. Because you're not going to be able to sync on an R wave here to be able to cardiovert this effectively. You defibrillate it. Give it mag. Because if they're stable, they're not going to be stable long. Okay. We're going to try to stabilize it, even if it goes flat. This one's always going to be sparked. You ain't going to find a patient in pulse with V-fib with a pulse. Ever. Ever. It's impossible.
You may find a unicorn, you never know yet.
I won't say it. What about this one? How are we going to treat it? Depending on the patient. Our assessment. What are we worried about with AFib? Clots. Stroking them out. Cardigan.
A medical. Seeing we took Cardigan off the truck. We don't know.
Yeah.
Medical.
Y'all use a Bedalol? Y'all use Bedalol? What about somebody, you pick them up and they have a heart rate of, say, 210 AFib, but they've been this way for 3 days now and it ain't went away.
Symptomatic, chest pain, shortness of breath.
Palpitations, lightheadedness, thought it'd go away. Are you gonna try to slow that down right away?
No.
No.
Good choice.
You can do a full pulse and then reevaluate.
H's and T's. But somebody that's been in a sustained tachycardia, especially AFib, will be a little bit more concerned about slowing them down. Because they've been like that, you know. So let's find that out. They flutter. If this one's unstable, rate's high. How we gonna approach it? If we have to cardiovert it, how we gonna do it? What's our rate sentence? We cardiovert it just like we do in our complex SVT. Because this one's a regular rhythm. You know, your RR intervals march out and you got a 3 to 1. But most of the time, a flutter is regular, where AFib is never really regular at any time. And you can see really high ventricular rates with flutter as well. Well, they must be high, but it can be a whole lot more than a rate of 70.
So with the AFib, if they were in a really high heart rate and you wasn't, so how you couldn't really tell if it was AFib or not, it wouldn't be a good thing to slow it down to be able to see.
You can slow it down with like a Denison,
Yeah.
but like if they have been in a heart rate that high, you know, whenever you get called out, you know, what's going on, you know, I've been having these palpitations and a headache and it's been going on for 3 days now. More than likely, that's how high the heart rate's been for quite a while.
Right.
So I wouldn't want to try to stop it or slow it down.
So you wouldn't use it in.
I would use the Denison because it's going to burn off really quick.
Gotcha.
But I'm not going to give them, you know, Cardizone or Labetalol or like that. Atrial tach. You don't see this one very often at all. Or I don't personally. I see more SVT or AFib. Here's a different block. First degree. We have to treat it. Not usually. How about a type? Which one do you think would be more symptomatic with a patient? A Mobitz type 2 or a complete heart block?
Complete heart block. Complete heart block.
Complete heart block?
Moments 2. Then it'll change. It'll most likely turn into a third.
Mobitz type 2 patients will be usually more symptomatic and usually gonna have to do a little bit more with them than a complete heart block. One of the last MIs that I ran with a patient in a complete heart block, his heart rate was 30 and he had no chest pain, no dyspnea, no. The only complaint was like he was having tremors that was less than about 15 seconds. I was like,
How old was he?
65, and his blood sugar was 365.
Yeah, it was-
So what'd you do for him?
I took him to the cath lab. He had a huge inferior wall on my 100% blockage to his RCA.
Hmm.
But he never once got symptomatic. His LOC never changed. Nothing. I put the pacing pads on him just in case. I wasn't going to get much pain. I gave him a little bit of a fluid bolus, transmitted EKG. Got to the hospital, and they couldn't believe whenever they were looking up, sorry, to 20, 24, 32. And he's just like, yeah, I'm fine, you know. He's like, I went to the hospital, I went to the doctor's office to get checked out for the tremors. So whenever I got there, you know, asking them, you know, what's going on, they hadn't even checked the blood pressure, nothing. They just know what his blood sugar was. I said, well, he's been in here for 20 minutes and you've got a blood sugar, but you didn't have time to get any, no blood pressure, no heart rate. No, he was having seizures, but you said it only lasted 15 seconds. So what? Okay, just let's go, you know, down in the truck. The first thing I seen was a heart rate of 30. He's a complete heart block. But he never once got symptomatic. And they would have certainly not done 12 lead on him.
Was he a big guy?
Nope.
No?
It was 165 pounds. It was 5'6". And the only history he had was hypertension and diabetes. He was a school janitor. And he didn't know why he was, you know, having the tremors. So he called the doctor's office and made an appointment. It's like, yeah, come right on in. What about atropine? Is it really going to be effective in anything past a first degree heavy block? What does atropine do? Increase the fire of the SA node. In the type 1, the SA node's good. There's just a delay, right? Once it gets down to a second degree type 2 and a complete heart block, is their SA node even the primary firing mechanism anymore? No, it's moved on down to the AV. It's really not going to affect the AV node. It may actually make it worse, make them more bradycardic. Junctional. No P waves. What do you think of this? What would you want to know about this patient? Pressure's good. What's going to cause them not to have any P waves or flat P waves? Whatever. Electrolyte. It's a hypokalemic. You have this flattened P waves. Flattened P wave. Ciliary junctional. Ventricular. What would be the first thing you want to know on this one? Yeah, they have a pulse. That's the first thing I want to know. That looks like somebody that's fixing to check out. So this big check mark right here, they're fixing to check out. And that one's fixing to stabilize. So it's atrial pace rhythm. See the spike that it makes? It's making the P wave. We'll talk about pacing in a little bit. What I want you to think of is like, when I think of depolarization and repolarization, okay? Everybody shoot a shotgun? Or a gun, any weapon? Discharge, right? So that's making it discharge, making it fire. It's got to reload. I've got to reload it. The heart has got to repolarize on its own before I can make it fire again, right? We're going to talk about some pacing, some things that can affect your pacing where you're not pacing effectively. Okay? Where you'll run into a RLT phenomenon when we're talking about fixed versus demand pacing. But somebody that already has a pacemaker, this is what it's doing for them. We don't do atrial pacing in the field. We do treatment pacing. Right? Here's a ventricular pace rhythm. If it depolarizes, got to repolarize. You hear that inverted T wave? Is it repolarizing? Dual chamber, heavy pace. Y'all need a break?
Yep.
So, we'll go into 12 leads now. Lead placement. All right. That's why we want our limb leads on the limbs. Okay. So lead 2, all we're looking at is from the right arm to the left leg, right? That gives us the inferior or a third of the inferior wall. Then we take the left arm, left leg. It's going to give us lead 3. And we're taking 2 and 3, combining them. That's giving us AVF. So that is a portion of the RCA, right? There's more to the RCA that we find when we do a 15 lead or 18 lead V4R. Right? There's your standard 12 lead placement. Where it goes, what we're looking at. Here's right sided. All we're going to do is take 4, move it over to the right side, 5 and 6. Right? Now if we're going to do a posterior, we'll do 7, 8, and 9 on the back side. How much elevation do we have to have for it to be confirmed as STEMI?
2 millimeters.
On the posterior lead?
Less than a millimeter, right?
So for it to be a STEMI, according to the HA, it has to be 1 millimeter of ST segment elevation and 2 or more continuous lead, right? Or 2 millimeters and 1 lead. On a posterior MI, it only has to be a half millimeter. Okay? That's more sensitive. And we'll talk about some things to look at for a posterior wall MI here in a little bit. But 7, 8, and 9, half millimeter. It's STEMI criteria. There's our geography. So, talked about this a few minutes ago. For the QT interval, it represents all electroactivity in one complex of a ventricular cycle. As there is no onset of the Q wave to the end of the T wave, if there is no Q wave, we'll start at the R wave. We're talking about a prolonged QT interval. Is that prolonged QT intervals, does that become important to anybody?
Yeah, certain drugs.
Certain drugs, exactly. What happens when we prolong it too far? Systole. Or we take a rhythm and make it torsades. So I put this on here. I'm not insulting anybody's intelligence. I do this everywhere I go. But the paper speed, because when I'm looking at the paper, and I'm talking about different criteria like a P wave or a QRS complex, how many boxes, rates, I can calculate my heart rate on my paper by marching out my R waves when I've got some really erroneous reading, that's giving me a heart rate of 200. Well, there's no way, it's picking up something that's not there, and that's what it's recording it as a heart rate. So I can count it out my heart rate, or maybe it's not giving me a heart rate as high as it should be. I've got a 12 lead in my collection. It's showing a heart rate of 0, and there's 2 complexes in each section. But it's got to be more than 0. So it's actually 40. We can measure it, taking our boxes and just knowing what each square means. And when we're talking about elevation, is it a half millimeter of elevation? Is it a 3 millimeters, 5? Or what is it? So here's our deflections. Our P wave represents atrial depolarization. Our QRS represents ventricular depolarization. Somewhere between R and S, we have atrial repolarization. Our T wave is ventricular repolarization. Repolarize and reload. So we're getting ready to fire again. Normal variables. I think we already covered that one. P wave. Small, rounded, upright indicates atrial depolarization, right? What if it's tall and peaked? Tall, peaked P waves, greater than 2.5 millimeters. Atrial hypertrophy. So if it's tall and peaked, is it left or right?
Isn't it left?
Right.
Oh, it's right.
If it's wide, it's left. If it's tall, it's right. If it's wide and tall, biatrial enlargement. So what would cause the atrium to be enlarged? When we think about muscles, whenever we work out, our muscles grow which way? This way, right? Heart muscle grows this way. So if it's having to work harder, pushing it from the right atrium to the right ventricle, is there an obstruction downstream? Okay. So if it's in the pulmonary artery, the right ventricle is not able to get it there. Well, it's backing up. So what's the right atrium doing? It's pumping harder, right? So our P waves will be tall and so we'd have right atrial enlargement. Okay. And if it's mitral valve, well, we'll see that here in a minute. I've actually got it 12 weight on here. I'll show you. But the mitral valve is right over where the left atrium is. So it's working harder because it's either stenotic or it's regurgitant, whatever. So it's having to work harder to push the blood down in the left ventricle. So it's wide and fat. Usually looks like an N, but it'd be at least 2.5 millimeters wide or 3 boxes, right? 120 milliseconds. Peak heart interval. 120 to 200 milliseconds. If it's greater than 200 milliseconds, we call it first gravity block. So it's atrial depolarization plus delayed AV junction. The last time for the atrium contract before the ventricles contract. Some of my illustrations might be a little weird. I made them. I'm showing some on the Corey. It took a little while to make some of them, but you get my point. Third gear, say node, fire, delay, radar interval. QRS, 80 to 120 milliseconds, right? And that's the ventricle depolarizing. All right. And the atrial repolarizes kind of in the middle. Well, what do we think when we have a wide QRS complex? Block. Okay. At least a bundle branch block, right? Okay. Depending on the rate, are we looking at a complete heart block? Are we looking at, whatever? But when we have a wide QRS, we're thinking some sort of a block, ventricular. Severe hyperkalemia. Anytime you have a potassium level above 7.5 milliequivalents, it can actually stop the firing of the SA node. Okay, so that's when you get into profound bradycardias with hyperkalemia. That
You
can
said
come
greater than 7?
greater than 7.5 milliequivalents will stop the firing of the SA node. A lot of times when you pick up a renal dialysis patient, okay, and they haven't had their dialysis and say they missed 1 or 2. They usually mean a wide complex tachycardia. That's hyperkalemia. Depending on how long it goes, they may be in a heart rate of 30, and a QRS of greater than 140, 150 milliseconds. The ejection fraction, you guys know what that means? Okay. Anytime their QRS is greater than 170 milliseconds, their ejection fraction is at best 50%. Okay. Normal 60 to 65. And the normal healthy individuals like us, that's what our ejection fraction is. If theirs is greater than 170 milliseconds, 50 is the best that they've got. It's probably a lot less. That's when you run into 25%, 35% ejection fraction. So they're not clearing the ventricle. What toxic effects of drugs would cause a wide complex tachycardia? Tricyclics. Okay, we're gonna treat a tricyclic. Bicarb. What other ones would cause a wide complex? Cause the complex to be wide. It can be fast, slow, whatever. Other medications.
No, Zofran can slightly widen it, correct?
What?
Zofran?
That'll prolong the QT interval.
You do, just that.
Calcium channel?
Calcium channel blockers affect more of the vasculature versus the heart. Beta blockers. Wide complex bradycardias. How are we going to treat them? Beta blocker overdose.
Beta blocker, I mean, looking on for a reason, right?
What about whenever they're 70 years old, they have dementia, they took their medicine, forgot they took it again, glucagon. Okay, what else? Somebody said something. Albuterol. That can help. Insulin. High dose insulin therapy. We do it in glucagon, okay? Because it's very positive, inotrope and conotrope, okay? And it's weight based, like 80 kilos, they're gonna get an 80 unit dose, like right off the bat, okay? Bolus. And then they're gonna get 80 units per hour. All right. We don't really worry about their glucose. You're going to check it, but honestly, in a beta blocker overdose, it's not going to really affect their glucose much at all. Okay? And then if you don't carry it, obviously they're going to be probably bradycardic, hypotensive, whatever. So you may be pacing them. You may not. You're trying to get capture. Well, I don't know why. Well, that's one reason that can affect your capture. We talk about pacing. What's the best way to confirm mechanical capture? We know how to check for electrical capture. What about mechanical?
Check
Pulse.
Okay. Where?
Central pulse,
Carotid
like
radial.
femoral or carotid.
Carotid's right here next to the pads. Okay? You're getting a lot of muscle movement whenever
Could be radial or femoral.
Okay. What is the most definitive way to confirm mechanical capture short of an arterial line? Because if you get an arterial line in there, what's making those waveforms? Pressure changes. Okay, if you're opening and closing valves, you're moving blood, right? Okay. Heart tones. That is the most definitive way, short of an arc line, to confirm mechanical capture. Okay, because a lot of times, even going anterior, posterior, you're having to crank up the juice pretty high, right, to get the capture. Well, they're down here, and most likely, they're probably unresponsive, right? That's probably why you're pacing them. If not, you're having to give them some therapeutic intervention to keep them from coming up off the bed. So they're still moving, okay? If they're opening and closing valves in the heart, we're moving blood, we've got capture, okay? Here's some different QRS patterns. This will be a little more relevant when we're talking about monobranch blocks, but since we had start talking about the QRS complexes, I went ahead and put this in here. J point. Why is the J point important?
That's how you, for ST elevation or depression.
Exactly. All right. There's some couple of different J points and their location. Anybody ever see a J wave? What causes J wave?
Hypothermia.
AKA the Osborne wave. Okay. The Osborne wave. What does it usually sing? What body temperature do you usually see it with hypothermia? Around 25 degrees Celsius is when it's the most prominent. It's very, very visual. Okay? Once they drop below 22 degrees Celsius, then they're usually going to irretractable VFib. So that's why we have to be really careful with it. But the J wave is most often seen in hypothermia around 25 degrees Celsius. Okay? What other causes that would you see a J wave in the normal population? That's got a temperature of 98.7 degrees.
Ischemia?
Ischemia.
Just this.
Close. What about vasospastic angina? Vasospastic angina. Vasospasm in the heart kind of causes this. You seen Prince-Meadows angina, where they have ST segment elevation because of coronary artery spasming. You do a 12 lead while they're having a STEMI. Give them one after glycerin. Goes right back to the isoelectric line. That's a J wave can be seen in patients, especially with a history of Prince-Meadows, but they can have vasospastic angina. They don't have a J wave. They can be hypercalcemic, okay, because of spasmin that calcium causes. Anytime you add calcium to something, you're going to get more work out of it. That's cellular biology. So if their calcium level's high, it can cause this. You can see it in head injuries. Mostly in hypothermia though, but in a normal patient it'd be vasospastic angina. What about a U wave? You see U waves a lot?
No,
Not
When
really.
you really pay attention to them?
no.
I don't usually see them that often. And you will not usually see them until their heart rate's 65 and below. Most times they're not even present, or even if they are, they're not really concerning. So, prolonged QT intervals. Okay, the QTC on our monitors will give us the rate corrected QT interval. Anything greater than 460 is considered prolonged. Okay, and that's when there are certain medications that we don't want to be given because we relax the heart too much and they're going to want to fire it out. There's one. Can you see right here? The QT, then the rate corrected QTC. 546. Anything greater than 460 is prolonged, right? Faster rates should have shorter QT intervals, right? This is 103. So it could be like 380, 390. Here's your refractory period. Relative and absolute. Has anybody ever heard of a commotion cordis?
What?
Commotion cordis. When you get hit in the chest, put your feet over rest. When you get hit at the absolute refractory period. Or relative refractory period, I'm sorry, not absolute. Hear about people getting hit in the chest and dropping dead.
Like what, baseball or softball?
Baseball, karate chop, whatever. But they take a blow to the sternum. It's right in that, right here. That's a pretty small area, right? But you can put them right into a VFib breath. Stimming patterns. Y'all good or don't take a break?
Break.
Break. Okay.
Can you explain the the left side?
Tall. And it's keep. Yeah, it's gonna have one that's tall.
So keep is
Keyway.
right or left?
Right.
And the left side is wide?
Yes. It's 120. So there's small.
So at least.
It's already 120 wide.
Like I'm fine with it. I just don't.
Wide and tall.
So
Bye.
this is what I'm asking.
So wide and tall.
Yep. Do I need to connect with one of these or?
I would turn off video and then probably record audio that way.
From Alamance County, I'm not from down there.
Okay.
You know Jeffrey Trump?
Oh, God, yeah.
Oh, God, yeah, you said. He was my partner in Forsyth County for a couple of years.
Oh, yeah?
So
Dave Lockwood.
You
love Dave. You love Dave, I hate Dave.
Tolerate it.
And mute yourself.
I ain't like a fan of him by any means.
I got you.
Yeah.
Link?
Link game.
Yeah.
Oh, it's got sparkles on it. Look at that.
I know him and Heather.
EMT.
I guess if they're still married.
I've been in Alamance County for the last 5 years. I worked up there for 4.5.
But then if you got
Matt Williams came.
20
hours.
Josh was my partner for the
And so these are probably on
Yes. Yeah, him and he's married to Gina.
yes, if they recorded it.
Just
Recorded.
because they've been acting.
No, they weren't recorded. And like this one, Glenn would have to,
He's pretty
Glenn actually
outspoken,
has
so
to
he's like, I
download
probably
the
should get back
file
up,
off
'cause
the
I don't let him
cloud
think I'm like
server
shit.
and then place it on like YouTube or a shared drive or whatever and give you access to it.
I hear they're having a lot of problems right now
So
too.
if you miss one that you didn't dial in for, you'll have to check there and see if he
Yeah,
recorded
that's
it
how
and
it's
he'll give you access to it. I'm sure he will most of the time, but it's not just you can log into the Zoom site and pull it right up.
So we do that, that'll show us participating.
What I believe is gonna do a critical care.
But you have to be connected the
He
whole
is.
time.
He is.
I just leave him
And you
somewhere,
still take
either here in the fire department, another room.
Yeah, went through it.
Yeah, we're doing another app.
Yeah, we were in the same class.
Yeah, we'll sit through it again, I guess. We'll go that far.
I've been studying for like the past year, so we'll see how it goes.
Then
So I want to sit through the whole class again, just to be sure that I got it.
the official answer is
We'll sit through it. It's been
do your call, whatever you listen when you're off call. He'll work with you to do something to make up the time that you're on.
I'm about 2 classes short from my degree.
If you're logged in and
I gotta finish that up too.
participating
So
as
I'm
a
always in class
sign
doing
in and
something.
sign out.
Do it while you're still doing.
Just kind of up to you how much
I started
time you
EMS when I was
report that
22,
you were away
so
from call.
I'm 26 now, so
Because
I've
we're
got
having to
forever
check calls,
to get stuff.
Yep.
When my call goes.
You want to slow down, the downhill now.
That's how Dad did, like I was gonna run with time after fire.
Pretty much same schedule as yesterday.
Oh, sorry.
Yeah. You what?
I got to drive back to West Virginia, I'll probably head out.
The hardest thing for them is they don't have any like.
Drop technician, if you can
on going work with the show, you're not gonna be, it's quick to make. They don't want to do shit.
I've heard good and bad things about them.
So, meds for errors easily learn to nickname self-centered.
Yeah.
There's money,
Oh, nothing.
do anything, stay crazy. That's what it is.
What you want to do.
It's really kind of frustrating. Your long circle has to be very good. And I think the problem is, I think the problem with the med center is they have to do that rectally.
So you work medic?
Gary,
You know Brendan?
I don't think it actually worked.
I know I have.
Because he works for us full time. He's our
Lonely driving.
new sergeant.
Scary driving in the house.
You're
I hit a deer with my truck.
Short guy, real friendly, talks a lot.
Thing jumped
Sort of
out.
most
Oh,
of
down
them.
here. Yeah,
I
Yeah.
go get him,
Yeah, he got that stuff.
Like he'll talk to you.
Hit something, either got
He is.
this side of,
He is, he's a nice guy.
Where you
on
guys?
this side of,
Because
That
we
was
had we had
way
another
over.
one. She's in the office now.
ambulance was back.
Megan Croxon.
Yep, I know her.
Evidently it slipped and went underneath the truck.
Megan and
I whatever it's back.
took
in,
Cruchy
broke
last
his
go.
back.
Mhm.
When I got turned
Yeah, I know
around,
her a couple times when I was
dragged
a student.
myself across the road
Megan's awesome.
to a clearing.
Well,
And
So
I sat there.
Oh,
I felt so bad. And I sat there with it for 15 minutes. I called the sheriff's department. They're like, well, can we get anybody out there to dispatch it? I'm like, it's like it's still alive, but it's, it's dying. I had my gun with me. That neighborhood, so it couldn't shoot it. And
they're like an
I
hour
was
and a
supposed
half
to have
from
a
me.
gun with me at work
So I have
anyway.
about an hour and a half. You know,
There's
nothing
we
close.
want
Charlotte's an hour from our house. Hour to
Died.
not even hitting traffic.
Later on that day, I went to the Humane Society, went out there and started petting dogs.
I've had my case down here. I don't like it. And I'm working up there.
So I went to,
I was kind of, it was right at the level of training. But occasionally it was,
Up there, I don't worry about anything.
yeah, my biggest problem is that tell folks to sit up. Well, I started off in fire, there was an EMS, and
We used to be here small time.
instead next to a pumper, we were running it for several hours to 8,000 RPM. I started noticing
That's my biggest fear, like with my FPC exam, I've never gotten to do it. I read about it, I can sit and read about it all day long, but I've never done it.
That's a lot of my problem is when I'm writing. I finally figured out why my handwriting is so bad. So that's why I miss
And still work fixed lane. I'm already certified in it.
You do this.
But still, that class too.
I am too, but I figured I'd try it one time.
Right, I mean, people never like.
If I like it, I can just go to ground for it.
It just I started out on RTS, and then if I ever decide, you know, obviously, the weight does probably long, and you got to die or retire.
It used to be like that here, and then everything started changing. Somebody used to have to die or retire if you get down here. Now, retire.
I'm comfortable where I'm at. I do all of Randy's for his critical care.
Mhm.
I got the line, and I got all the ALS put in the truck. I'm just gonna get on whatever truck we go from here to Charleston or.
Yeah.
The last 24-hour trip before they went to 12.
He paid me well for it, so that was good.
I was driving around.
Still kind of want that part-time EMS, but I don't want my skills.
That's me too.
I don't think I could ever really truly leave.
Yeah, I mean, that's the thing for me, like, I've been there, but I'm not to that point. But I'm not to that point where I'm ready to decide to use it.
No, I'm not even, I could never do it.
where you working?
Just wait for time, 10
No, people, I've heard great things about
You would think, but with everything being so close, if you really want to work in a you need it. Yeah, one way. You know, and that's so it kind of, when I was
So that's their PCP, the emergency department.
Right, I mean, I'm ready for more.
Oh, you can tell me to move. I don't mind. He's like, I have an opinion. Do I?
That's what I would get say.
Well, how's Tyler?
He relieved me one morning, but I'm not working anymore, so I don't know. He seems to like it. He got full time.
Yeah.
I got my national register medic in
Did
93.
he used to be your partner?
Back then,
Yeah, he
cut
was.
and dry.
Lives
Now
Yeah.
it's just,
Yeah, he's, I worked with him a couple of times. Basic and. I worked with him.
He has a good attitude. I can see that. And he's real energetic, ready to do stuff.
Yes.
Yes, he's very high strung. But I don't have a problem. I mean, he seems really super nice. I actually work with him. He works on C shift and I work on B shift. So.
I'm a hands-on, I don't like. He knows cardiology really.
Yeah. I like cardiology.
Well, that's the thing.
So we can't get lost for well, actually, one way back in 1980.
That's why a lot of them fail and down with the state test and the state test.
Thank you.
Right, yeah, I was in Charlotte Fire Academy, they sent us to that room and they're like, yeah, and it was easy, you know, like, Yankee Texas, the same thing. I guess it's well, no, I grew up in super tiny rural schools, so.
Are you still
This is classes.
probably had a copy and paste 2 years ago. She's not, that's fine.
And I got an advance class. Probably about the same time.
I'll tell you, I was in Salt Lake City.
So you're literally having to do
December.
having to do that.
Or it's like,
I hate it.
Right.
Friday.
To me, it's so
Friday night, we're at a Christmas party, I'm out there getting shrimp or whatever. And our daughter's house. Project manager, our business manager, big guy. Cutting trees on the right of way. Landed a tree.
Right. Yeah, well,
And so
I never got
he
it.
goes,
That's what I was thinking.
who wants you to do?
Get lunch. You already get that.
I know how to work. So that's what I'm.
So you want me to fly from here back to North Carolina, drive 2 hours to Raleigh, back to Montana. At that point, then drive another 5 hours back to West Virginia. And then do the report.
All right. If y'all ready to start back, we'll get started back. If at any time you can't hear me, let me know. I'm talking about mumble some because I talk really fast. So occasionally my brain's processing stuff faster than my mouth can get it out. I might hum or mumble or chew my tongue, something, I don't know. But if you can't hear me or understand me, let me know. I won't get offended, I promise. So we're gonna talk about STEMI patterns, all right? All right. So ST segment elevation, that's gonna show us injury, infarct, all right? And it's gonna be in leads facing the injury zone. Depression will be our reciprocal changes, all right? And it'll be seen in the opposite leads. And we're gonna talk a little bit more about that as far as what I want you to think of as your heart, just like a glass box, okay? A glass mirrored box, all right? My 12 lead, I'm looking at this way, right? I'm getting one look at the heart. What I see on this side can be my reflection of what I'm seeing on the back side, okay? So when I talk here in a few minutes about our wave progression, all right, that's what I see here, but on the back side, that's actually gonna be a Q wave, okay? That's why it's important, and that's why a lot of STEMIs get missed. Actually, 33% of all acute MIs are missed on the first 12 lead. So that's telling me 1 out of 3 is I'm getting, or I'm missing. And that posterior MIs and right ventricular infarcts, things like that are missed because we see something funny on this side, but we don't go around and take a look on the back side to see what it is. Okay. Elevation of 1 millimeter or more in 2 continuous leads, or 2 millimeters in 1 lead, except V1 and V2. You gotta have 2 of those, okay? Is a STEMI. If it's in multiple leads, it can be pericarditis, it can be a dissecting AAA, it can be Prinzmetal's angina. There's several things it can be if it's in all leads. It can be a global MI as well. But if you see elevation everywhere, depending on your patient at the time, and with pericarditis, it's going to be positional, right? They're going to be laying flat, they can't breathe, they're suffocating, they're about to die, but you set them, semi-Fowlers, I can breathe. Well, that's when that pericarditis, that ST segment elevation is going to go from 3 millimeters and all them leads to nothing. We'll go back to the isoelectrical. And with pericarditis as well, it can be, if you see leads with ST segment elevation that does not geographically correlate, okay? If I've got some in 1, I'm thinking AVL, V5, V6, but I've got it in 1, I got some in 3, and I got some over here in 4. V4, it's like, but I've got the elevation, That should kind of key you into that could be pericarditis, all right? We'll talk a little bit about J-point knots here. That's something you might see with pericarditis as well. So elevation, STEMI criteria, according to AHA, is 1 millimeter of ST segment elevation in 2 or more contiguous leads, or 2 millimeters of ST segment elevation in 1 lead except V1 and V2. Okay. And the ST segment, is it concave or is it convex? All right. If it's concave, most of the time they won't even call it a STEMI. That's be convex, okay? And this is something that is generally seen, okay? When you're looking at V1 and V2. All right. That's where you see those complexes that kind of look like that. Now, like, no, it's not STEMI. Reciprocal changes. Like a balance beam. If we get off on one side, we're gonna fall. Well, if we put all the weight on one side, we're gonna fall on that side. Well, if we have it in 2 through an AVF, generally we'll see it in 1 AVL, V5, V6, depending on if they're right, left coronary dominant. But this is just generally, you'll see your reciprocal changes 1 AVL, V5, V6. Can they have a STEMI and not have reciprocal changes?
Sure.
Okay. What does reciprocal changes mean to me? I'm cutting the blood flow off up here. Somewhere downstream is going to be affected by, okay? That's where I'm getting my depression from, okay? It's just like, I don't know if you've heard of the fingernail principle. You start squeezing that finger, okay? It's going to start turning white, right? Well, that's a clot sitting in the coronary artery. What am I going to do to restore blood flow to that finger? Got to take the pressure off, okay? Am I going to do it with nitroglycerin? No, not really. Think about somebody with an 80-year-old man. He's got 80 years of atherosclerotic plaque, and his coronary arteries are like a garden hose. Am I going to give him a pinch of nitro and everything's going to dilate? Not hard, okay? And with that much atherosclerotic plaque, he probably, you know, he's probably going to need a lot more than just nitroglycerin. But for me to take that pressure off, he needs a cath, right?
Yeah, last slide there. Why won't they call it?
What do they call that? Do you see, does it come back to the iso?
Yeah, it's really not everybody does.
It's just something, especially in certain leads, that they will, like V1 and V2, and I say you got to have at least 2 millimeters. Well, that's something that you're really going to see a lot in V1 and V2. So there might be a millimeter there. Over here, there's about 3. Okay. All right. And you see the morphology there. And we'll look at some, when we look at some STEMI EKGs in a minute, you'll see how that convex shape is seen a whole lot more with a STEMI versus hyperacute T waves or early repolarization variants, things like that. Does that make sense?
Yeah.
Okay. Reciprocals. ST depression. So for me, I'm thinking an MI is occurring somewhere. I'm gonna go find it. You know, if it's in 2, 3, and AVF, you know, does that mean I've got something going on anterior or is it posterior? Isolated ST depression is not really. It's kind of rare. I mean, just have depression and not be infarcting or not be having a non-STEMI, something like that. If they've got depression, they need to be evaluated somewhere.
You're basically saying that's the smoke of somebody's fire.
Exactly. So. Yeah, there's a fire somewhere. Keep hitting the wrong button. I want to mash the red button, and I keep hitting the back and forth. But it's a sign of ischemia. All right. On to ischemia. Inverted T waves. The T waves facing the ischemic zone. Upright leads that are opposite on the side of the heart, like we talked about, the glass-shaped box. What I'm seeing on this side is a direct reflection of what I'm seeing on the back side. So that's when I've got, you know, ST depression over here. I go around to the back side or flip it over. That's elevation. Then I confirm it. All right. There's transmural and subendocardial. All right. Transmural extends to the whole thickness of the heart muscle because of a complete blood supply. I have put a tourniquet on my finger instead of just squeezing it, right? If I'm just squeezing it, it's losing blood flow, but once I release it, I'm going to get blood flow back to it. So that would be the small area of the subendocardial wall, sacroceptum pavillary muscles. Transmural, ST elevation, STEMI, subendocardial is non-STEMI, right? That can be your ST depression and 2 or 3 different leads, but we've done several EKGs and we hadn't found any elevation. That's just the beginning. They're probably going to start infarcting shortly. Here's our ischemia, injury, and infarct. Transmural and subendocardial. Can y'all see that okay? With the colors.
Did you draw that?
I didn't draw that one. No. I've done that one with PowerPoint. I did draw several of them though. So subendocardial here, we're just starting and working our way in. Once it's transmural, it's already down deep into the tissue. How much heart tissue has to be injured before they're considered in heart failure?
40%.
Yeah, damage to 30%. They'll classify them in heart failure. Okay. And there's different types of heart failure. There's systolic and there's diastolic. Okay. So they're either having trouble clearing the ventricle or filling it. Okay. And that can depend on, you know, we're going to talk about the difference in LADs and where they affect different parts of the heart as far as conduction and valves and different things. But yeah, we'll talk about that. We'll get him set. Can y'all still hear me okay? All right. Zones of infarction. Q wave infarcts, okay? They have pathological Q waves that is dead tissue that doesn't depolarize, all right? To be a pathological Q wave, all right? It either has to be 0.04 seconds wide, which is one of those small boxes on the paper, or it has to be 1/3 the depth of the height of the R wave, okay? I think I should have, yeah. So that's physiologic. So the depth of the Q wave is at least 1/3 the height of the R wave, okay? So physiologic Q waves, most of us have physiologic Q waves, and that's an abnormal finding on all leads on a normal 12 lead. So we call it QRS complex. Most everybody has them, and it's just an abnormal finding. All right, and a Q wave is the first negative deflection before any positive deflection. Subendocardial, non-Q wave, and the damage is limited to the subendocardial region. This is transmural full thickness MI. All right. They have a lot of damaged tissue that have Q waves. There's some new criteria coming out, AHA, as far as whether they're going to take patients to the cath lab if they already have Q waves. Okay, that's something that we'll see on the next update, but it's going to be whether they have Q waves or not on the EKG. And if you have, has anybody seen a STEMI without Q waves and they have ST segment elevation? They don't have the pathological Q waves. You can, but it's pretty rare because it's already, once it infarcts, there's tissue dying right then. Strain patterns. It's the hallmark presentation of hypertrophy, but this is the, when we were talking about the injury zones a while ago, the strain pattern, like that muscle we talked about overworking, is that left ventricle trying to clear. If it's with LVH hypertrophy, you're usually going to see it in V5, V6 most of the time. If it's on the right side, 2/3 AVF, it's usually indicative of right ventricular hypertrophy with like cord pulmonale, whatever, when they're trying to clear that right ventricle because they have a pulmonary embolism or like pulmonary fibrosis, something like that. Some lung tissue disorder will cause a strain pattern on the right side. So that would be our right ventricular hypertrophy. Left is seen a whole lot more with hypertension, especially with long history of hypertension. But you can see this in patients with non-STEMI. I'll do this one. I had to put all of those stuff in there. This is just kind of a diagram of the axis in the heart and how each lead is looking, you know, at the different locations. So here's our coronary arteries. It's our right coronary artery coming off. So we're looking at 2, 3, and AVF. Here's AVR. I'm kind of big on AVR, what it means. There's V1, 2, 3, and 4. So that's our left anterior descending, right? Circumflex, our wraparound, high lateral. Okay. localization, RCA. Proximal occlusions. You know, tell the difference between a proximal right coronary artery and a distal. For giving nitroglycerin. Okay. We give nitroglycerin to STEMIs with ST elevation 2-3 ABS.
You can.
You can. Okay. We do V4R. All right. We have ST elevation. What's that mean to us? Not that. It's proximal. Okay. So they're going to be, we're going to drop the preload, right? And that is 90% sensitive and specific. If they have ST segment elevation and V4R alone, the right ventricular infarct, that's a proximal right coronary artery occlusion. We give them nitro and their pressure is going to go. All right. If you do V4R and there is no ST segment elevation, it's a distal. So it's already past the right ventricle. You're not going to bottom the pressure out. They may have a pressure of 170/80. Okay. And give them nitroglycerin. You ain't going to bother them. Another thing you can look at is if the ST segment elevation in lead 3 is greater than it is in lead 2, 65% chance that it's probably right ventricular involvement. Okay. But you would still do it before you hit them with that 400 mics under the tongue and sent their pressure spiraling down. You know, that's the quickest way to know if they have right ventricular involvement. Just give them a nitro and find out. You can give these patients quite a bit of fluid to augment their preload, and you're not going to hurt them. You know, preload, if the pressure coming back in, so it ain't like you're going to put them in flash pulmonary edema. All right. Inferior, through their AVF, it's the inferior wall, okay, right coronary artery. We'll talk about some special considerations too here in a few minutes with RCAs. There's a posterior descending. R-wave progression, all right. The normal R-wave progression should make the transition around V3, V4, okay? Now, V3, V4. If it is occurring earlier, all right, the R wave is progressing faster. That is aggressive or progressive R wave progression, all right? When I talked about the heart as a mirrored box, all right, that aggressive or progressive R wave progression on the backside is a pathological Q wave. That's a posterior wall MI, all right? When you do V7, 8, and 9, you're probably going to see ST segment elevation. Okay. If the R wave in V2 is larger than lead 3, it could be a sign of a previous posterior wall of eye. All right. Posterior occurs often. Well, it's something that occurs quite a bit, but is not found quite as quickly just because of the standard 12 lead. You know, everything's good. You take them all to the hospital. Well, they're still in pain. You give them nitro, they're still hurting. You know, they're waiting on labs to come back. Well, their troponin's now 520. So, wow, they've been cooking for a while. Well, they were infarctors when you had them. But if you don't, you know, put more leads on to shoot another 12 lead, you're not going to find it. The normal R-wave progression. LAD. So why do they call the LAD the Widowmaker?
Kill you dead.
Do what?
It'll kill you dead.
It'll kill you dead? Okay, why?
It affects the largest muscle.
It affects the largest part of what?
The heart, the left ventricle,
Okay, besides the left ventricle.
surface legs. Yeah, the surface area.
Depending on where the occlusion is, whether it's proximal or distal. I mean, it could be a left main. And you know what the treatment is for a left main? It's 30-2. Because you're probably doing CPR if the left main occludes. Okay? But the LAD, The LED feeds the most of the conduction system. Right? Well, we talk about inotropic, chronotropic, and dromotropic. We're talking about rate. We're talking about squeeze, electricity. Okay. If you lost conduction, how are you sending the signals? Okay. Well, the LED feeds the anterior hemifascial, the posterior hemifascial, and the right bundle branch. Right. It feeds the anterior and the anterior hemifascial as well as the right bundle branch. The posterior hemifascial has a blood supply that comes from the right coronary artery. All right. If they have a pre-existing left bundle branch block, then they've cut the blood flow off to that. All right. So everything downstream's off, it's out of service. The right bundle branch is the only thing that's actually sending signals down, and they can have relatively normal conduction through the heart with the left bundle branch block if the right one's working properly. You throw a clot in the LED, what happens? Defib arrest. Yeah. With the LED, it feeds the papillary muscles that are attached to the mitral valve. Okay. Coordinate tendon A, mitral valve, papillary muscles. If you have a LED occlusion, it can actually cause papillary muscle rupture, papillary wall infarct. It'll cause a mitral valve, which is the last valve to become incompetent, invert. You'll have flash pulmonary edema with you with an LED. Has anybody ever seen flash pulmonary edema? It's pretty violent, and you can't get it suctioned out fast enough. That can happen with an LED. But the biggest reason with the Widowmaker is because of it cutting the conduction off. You know, it's like flipping that light switch. Circumflex, there's high lateral, low lateral. It can be a big issue as well, depending on the location of the clot. Inferior STEMI. There are cervical changes. Okay. What about pathological QA? Right there. There. We have our reciprocal changes as well. See how down here in 5 and 6 we almost have a strain pattern? Another one. I think. Let me check something. Oh yeah. This one I think was the same. Maybe the same patient. I had done this one. See you have elevation in 2, elevation in 3, and AVF. Is it greater in lead 3 than it is in lead 2? That was a right ventricular infarct too. What about this one? You got elevation everywhere, don't you? This one got a balloon pump. It's pretty straightforward on that. Reciprocal changes. Does this one just stick out to you when you first look at it?
B3 does.
B3? With the green circle around it?
No, it's in the yeah.
PVC. Look at lead 2. Would you even suspect to even look? Is there anything at lead? Can I make that thing bigger? How about these pathological QAs here? Would that alert you to take a better look?
Oh yeah.
That's the only thing abnormal about that when it's AFib. That's lead 2. So when I'm looking at it, I'm like, let's dig a little deeper here. Then you see this. Got you now. Other than that, normal end. Interior lateral. So depending on where this occlusion is, it's gonna be a pretty big deal, right? We know we've got the LAD and the circ because we're high lateral and V2 and obviously V3. See that? And 4. See here's our concave and convex. Okay, that's concave. That's convex. This one still is parked in, but
That's our side fleet. Tell me they took that one to the cath lab.
yeah, that went to the cath lab. And, trying to remember one of them. He did good till I moved him over. Then he went. Yeah, he got the white coat syndrome, I guess. About like around 50 yards, maybe a little longer. Got it back. Did I stop something? I was just trying to bring that pop corner out of the way.
Someone's not got their
Mute
mute mic, so I did.
Okay.
Daniel didn't even have his mic function on, but everybody else is muted.
So you read lips.
So they can talk to you.
Oh, okay.
Yeah. So if they had a question, they could be
Okay.
like
They're probably asleep. My monotone voice.
at first worst.
Thank God. I thought I was worse. Hey, you mess up my clicker.
Click on your PowerPoint icon at the bottom.
Okay. AVR. How many people have heard AVR doesn't really mean anything? It's, yeah. Don't you believe it? Okay. It does. Okay. It's EKG electrical activity from the right superior portion of the myocardium, including the right ventricular outflow and the basal portion of the intraventricular septum. All right. Usually, with it, you are going to have elevation here in V1, V2. Okay. We've already got the criteria there. They got pathological Q wave. All right. They got 2, 3 AVF. We already got our reciprocal changes. No. This is indicative of a left main. Okay. So if they have elevation in AVR, augmented vector right, okay, better get them to the cath lab. Does anybody know what that is? Scarbosa criteria. Okay. Do what?
Scarbosa's criteria.
That's right. Either way.
Yeah.
So one lead anywhere with at least 1 millimeter of concordant ST segment elevation. Concordant mean in the same direction. Okay. We have, I drew this, so you probably can't really tell. We have 1 millimeter, maybe 1.5. Okay. This is the new modified Scarbosa criteria. All right. One lead of either V1, 2, or 3 with at least 1 millimeter of concordant ST segment depression. All right. And then one lead anywhere with greater than 1 millimeter of ST segment elevation and proportionally excessive discordant ST segment elevation as defined by 25% of the depth of the preceding S wave. S wave. Okay. Here's your isoelectric line. We have 10.5 down and 3.5 up. So is that 25%?
That's in the presence of a left bundle, right?
Yes. Left bundle and paste but it's more prevalent in left pre-existing left monobranch blocks. Okay. That's your new modified Scarbuster criteria. This one, they use a number system. This is supposed to be 4 points. It's supposed to be 3, and this is supposed to be 2, and you're supposed to have 4. I think 4 points. So if you got this, cath lab. This and this, cath lab. So you transmit it, they'll read it. They know what Scarbuster is. They'll let you know in just a minute. I know how to read a 12 lead. The reason I put this in here, one of the first classes that I taught in Virginia, I worked with their director, and I taught a couple classes up at Popper's Gap, and he said, "I want you to come teach a 12 lead class for me." He said, "Because my guys have been told and been preached to that you cannot diagnose a STEMI in the field. The physician up there told them you have to have lab values to confirm a STEMI."
What?
Which is horses' ass.
But that's what we tell people. I mean,
Myoglobin is not cardiac specific, okay? I can tell you out of a car at 70 miles an hour and your myoglobin is going to elevate, okay? It's not cardiac specific, but it will elevate within 1 to 3 hours, okay? It'll peak in 6 to 10, it'll last a day. That's your normal range, 10 to 95. CKMB, all right, there's creatine kinase, CKMN, CKBB, and CKMB. All right, BB is brain, MM is muscle, MB is cardiac. It is the first cardiac specific enzyme to elevate. It takes 3 to 4 hours, okay? We're not baking a cake here, all right? If you see ST segment elevation, it's a STEMI. I don't need a troponin I to get confirmation when it's going to take 4 to 6 hours. Now, mind you, that is depending on the size of the infarct, depending on the patient condition, okay? It may elevate quicker, it may take longer, but if they have ST segment elevation, they have Q waves, they have ST depression, they have reciprocal changes, they're going to a cath lab somewhere. By air, by gram, sea, however, I'm getting them to a cath lab. All right.
I got a quick question. I mean, as far as his, that medical director's way of thinking, though, then why is all the hospitals going when you're bringing them in, you're going straight to the cath lab without getting guys?
Do you know very much about Virginia? Okay. I'm talking about Galax, Virginia.
No.
Okay. There's I think their physician's actually like not even emergency medicine physician. It's like a family care, but they work 1 day a month or 1 day every so many weeks in the ED.
Right.
But basically up there, they don't even have full-time county services. Okay. Like some of them's volunteer,
Right.
with a rescue squad. Some of them's paid. In the city of Galax, they are paid, but they have to take them straight to Twin County. Okay. They have been afforded the decision if they want to fly them. You confirm it, transmit it to Baptist, Forsyth, wherever they're going. You can call for the helicopter. Otherwise, bring them to Twin County and we'll deal with them. Well, if I'm gonna damage heart tissue, that's it's a class 1 intervention by AHA. If 90 minutes from onset of chest pain till they're in a cath lab is class 1 intervention, right?
Mm-hmm.
Well, they've been hurting for an hour. Now they call, it's indigestion. Well, I took my Pepsid, I took my Zantac, whatever, okay? Well, you take them to you get there and they're having a huge STEMI. Well, I've already lost an hour. I only got 30 minutes left, Take them up there. Well, what are they going to do for them? They're going to give them thrombolytics. Well, what if they don't meet the thrombolytic criteria? Now I've wasted another 30, 45 minutes. I'm already outside my window of my class 1 intervention. Obviously, I can take them and get them cath, but how much heart tissue am I going to damage before I'm like, send them somewhere they can get definitive care?
Right.
Okay. I had this guy with a huge anterior septal MI. He's like, I think I just got gas. I just can't get it to go away. Well, how long has it been going on? Since yesterday morning. You tried everything else and you're just gonna wait all day or what? You know, he walked to the truck, you know, because he's walking out from under his carport right to the truck. He's like, y'all got anything for gas on there? He's like, I took Pepsi and whatever else. He said, I just can't get it to go. He said, I just got a big gas ball right here. He doesn't want to go nowhere. I was like, well, let's take a better look. He's kind of obese, and as soon as I put it on him, I was like, just get out of here, go. He's like, what's going on? I was like, you're having a heart attack. He's like, no way, it's gas. I was like, no, it's a heart attack. He didn't understand. He had more than a bubble. He had a clot sitting in there. So, atrial and ventricular abnormalities. We've already talked about atrial enlargement. Yeah, we'll talk about atrial and ventricular differences. Right bundle branch block. So if it's a bundle branch block, the QRS has to be greater than 120. Right. All right. This is a R. This is what we call a RSR prime. Okay. It's positive deflection in V1. You've heard the turn signal criteria. If it goes down, we're going to the left. If it goes up, we're going to the right. Okay. All this means is the right ventricle depolarized last. Our heart should be in sync, right? And it should make the pretty PQRST complexes. This RSR means there's a block, left ventricle depolarized first. Okay. There's the right ventricle depolarized first. Have a negative deflection. It's wide, greater than 120 milliseconds. We got a left bundle branch block. There's a right. See, it's tall. That actually is probably biaxial enlargement there. There's a good one. On 12. So it being in lead 2, what do you think one of my considerations would be for that location if I have that right atrial enlargement? What we talked about a while ago. The blood going from the right atrium to the right ventricle. It's enlarged. I got low sats, chest pain, sudden onset, sharp.
Pulmonary artery occlusion.
Pulmonary embolism. No. Does that always mean it? No, it doesn't. But when I start having these clues with a patient presentation, we'll talk about a S1Q3 T3 here in a little bit, which is something you'll see. But I'm also concerned when I see right atrial enlargement, right ventricular hypertrophy, right strain patterns, things like that, start keying me into which side of the heart my blood flow. I know this is on the right side, so what's the obstruction that's causing this to occur? Left atrial enlargement. It's usually mitral valve. Can be regurgitation. Left ventricular hypertrophy. There's a couple of different criteria for measurements, okay? If the deepest S wave in V1 or V2 plus the tallest R wave in V5 or V6 is greater than 35, and the patient is at least 35 years of age, the criteria for left ventricular hypertrophy has been met. Okay? If the R wave in 5 and 6, if the R wave is greater than 25 and 20 in V6, LVH criteria has been met.
Why the age of 35?
That's a good question. I don't know. I guess they're looking at the voltages, okay, and what we talked about, like the strain patterns, okay. A normal hearts with normal physiologic function that don't have plaque and everything else, they shouldn't be creating a voltage that tall without some sort of stressor.
Okay.
Like the strain pattern I showed you, that's because of that much working.
Yeah.
You'll probably have a strain pattern with something like that as well. But the R wave will be at least that tall.
Okay.
In lead 2, it's greater than 20 millimeters. Left ventricular hypertrophy, the criteria has been met. It's pretty obvious, like this is old paper. There ain't 25 millimeters of paper here to get a recording on. It's off the paper, so it's pretty obvious. I'm gonna call it. See the strain pattern? And then when V1, V2 has met our criteria. And also meets left bundle branch block criteria. QRS is 140 milliseconds wide. Right ventricular hypertrophy, or not hypertrophy, hypertrophy. We're talking about the right ventricular hypertrophy. So, the height of the R wave in V1 will be at least 7 millimeters or greater. Right ventricular strain, this is what we was talking about. You'll see it in 2-3 and AVF. With that strain pattern, pulmonary hypertension, a pulmonary embolism, especially whenever you couple it with like right atrial enlargement. You know, the right atrium and the right ventricle is having trouble pushing blood. Why? You know, you'll see it a lot in pulmonary fibrosis because that is a chronic disease that's causing that restriction of flow. And acute pulmonary embolism, you may not see it, but people with like chronic pulmonary embolisms, they shower them all the time. Who's at risk for a pulmonary embolism?
Somebody just had surgery.
Somebody that had a surgery,
Stagnant.
pregnant,
Smoker,
smoker,
cancer.
cancer. Why cancer?
I don't know.
What's that mean? They're hypercoagulopathic. Okay, so their blood is a lot thicker than viscosity. Okay. But truck drivers, people that are immobile for long periods of time, okay. I've got a picture. I've got a 12 lead, and I'll show you this one, T3 pattern. It's of a 17-year-old. Okay, he's a little obese. He actually thought he had the flu or pneumonia. He come in, he's blue. Okay, sats are in the 70s. Lungs sounds like crap. Okay, I thought, well, you know, maybe you do have pneumonia. Anytime you give patients with low sats oxygen therapy and they don't respond, you probably ought to think PE, okay? Because blood's flowing through the pulmonary circuit and it's not getting oxygenated. All right? Sats in the 70s. Non-air breather, 15 liters a minute on a 17-year-old, ought to bring it up pretty quick. Okay, it didn't get above 80. All right. Anytime you have a patient with no history, they have no history of asthma, COPD, they don't even smoke, nothing. They have bronchi rails, better be thinking PE, okay? They'll usually get tachycardic, obviously, but they'll have, with S1Q3, T3, we're looking at the right side, right ventricle to the pulmonary artery, the pulmonary vein. On the left side, they're going to have the strain pattern, or inverted T waves, or ST depression, V1 through 6, okay? Because it's going from the right to the left. When it goes past the lungs, they get oxygenated, so when it comes out the left side, it's ischemic. There's a right ventricular strain, right ventricular hypertrophy. This is deep S, pathological Q, inverted T. S1, Q3, T3. See how we're inverted T waves? 1, 2, 3, 4, 5. Does that make sense? That's actually easy. There's my references if anybody wants to look. I got several pages of references if anybody wants to look further into what I'm telling you. Whenever we're going to break for lunch here in a minute. When we come back to lunch, we're going to talk about some other things on the 12 lead that we can see, especially, I don't know if it goes or not. I wrote an article. It's going to be published next week, whatever. It's coming out in the EMS World magazine, and it's criteria that should be treated as a STEMI equivalent. Okay, ST depressions, Welland syndrome, de-winter T waves. You guys ever heard of that before? I'm gonna show it to you. If you have 8 surface leads with ST depression, that might be the one that you do a 15 lead on, 18 lead on. You still don't find elevation. Well, it's probably they're going to get it's either through vessel disease or whatever. They're probably going to get a cath, maybe an Impella, maybe a blood pump, bridge them over. They might have to have a heart transplant. But we'll talk about that after lunch. We'll talk about some EKG changes, especially with potassium levels, sodium levels, calcium levels can make a lot of effect. The different phases of the action potential, where the medicines that we give and how they affect the heart and why they affect the heart. Okay? I don't know what time you want Joe to come back, but I'll give you time to go eat. Can you still hear me okay? Did I mumble that time? You good? Don't mumble anyway. I don't know. Let me go ask Corey. Watch time.
Say what? Even my RNIs and everything, it doesn't just shoot. It's not getting in to break my down.
All right, lunchtime, be back about, we'll start at 1 o'clock, so you're about 5 minutes early, so be back at 1. And then Annette's actually processing the rest of the score stuff now to give you the areas on that test that you may want to review. So she'll have those for you. And if you are having to leave early, cut out early, whatever, if you'll email Annette later, if you can't stay and get your stuff, she'll be able, I'm sure, to scan it or take a photo, email it to you so you get them that way. Hers should be Annette at Premed.
Send over the test scores.
Yes, she breaks it down to give you a synopsis of like the area that you should focus on studying and reviewing based off that 100-question test.
But we can't review them before.
Spags, we go.
No, because you can't leave with the test anyway. You get a synopsis of it.
I know we were supposed to review the test.
Hey.
Yep.
Whenever you're done, before y'all leave. Are you done?
They're done. They're getting
Um,
ready to head to lunch.
if you want to look over the test and you want to know what your breakdown is, I can give it to you now. If I know some of you got to leave. If not, Annette will be in with cards that have the specific breakdown that you can keep after lunch. Sometimes this afternoon. So I'll give you either option. If you want to see now, you want to know now before we go to lunch,
Yeah.
I'll give it to you. If not, you can get it after.
And then I told them if they had to go to leave or whatever, they could email in. I'm
Yeah.
sure she could shot it and email it to them. So
We get a chance, our
So,
daily
and
test, like
ops,
to actually look at the test.
it was a
and see
total
what
of
it is and what
10.
the correct answers are.
the daily test, you should.
Airway.
I don't think she keeps those.
Just on-
You will get those back. I just haven't graded the second one yet.
Okay.
Did you get your one back from yesterday?
I got scores.
That test.
It don't have the test and it had the test.
Okay.
So
You
you'll
should
get
get
it.
both of them.
You'll get back today.
Airway was 20. Medical.
Sheriff,
Huh?
what time you coming back from lunch?
One
Thank you.
ish. Heavy on the ish.
One.
Okay.
and it wouldn't let me. It just sat there and spun. So that may mean they hadn't started back. It's just sitting there spinning, but I seem to have a good Wi-Fi signal.
All right, you should be good to go.
Everybody's good and full, so you can go to sleep on me. All right. We're going to talk about pacing, some different things you're going to run into on pacing. Some of it is only going to be applicable to patients that already have a pacemaker in place. Some of them are going to be relative. Has anybody ever transported an intraventricular pacer? It's pretty simple. It's a box that sits up on them. It's got a guide wire that goes down and is pacing them. We'll talk just a little bit about it. We'll hit on it. I'll explain to you what things like sensitivity are on those. We're going to talk about how many of you transport patients from one hospital to a higher level of care that may be getting paced already. You've got to get them. You've got to transition them from that pacemaker onto your pacemaker, and go down the road with them. We're going to talk about that, how to transition them. Dr. Pyre, Dr. Whalen from Baptist has come up with a way that we do it. Very effective. Keep it from losing capture. So we'll talk about that as well. Anybody in here ever had to pace a kid? We've had a couple recently. They were, well, I say kid, they were like 14 and 15 years old. Overdose, bradycardic. They were pacing and giving pressors and lots of other things because they hadn't got them reversed. So we'll talk about some of that stuff. So pacing, we're going to set the heart rhythm. Usually ours is by the sinus node. When our SA node's knocked out, like with hyperkalemia, the heart uses another side, uses the AV node. Sometimes the patients will have an artificial stimulator in already. They've already got a pacemaker in place. And that's what I had showed you earlier on the atrial pacemakers versus the ventricular pacemakers, and then dual chamber pacemakers, atrial and ventricular pacemakers. You would be surprised how many people in their 30s and 40s now walk around with a pacemaker. I've got one person in particular I work with. I'm 38, she's 42. She has a dual chamber pacemaker. She's had to have it replaced 3 times. The wires can go bad. Batteries, electrical disturbances are something we'll run into a lot of times with electrolyte disturbances, it's something we'll run somebody that has a pacemaker in place. It's not working properly. It may be a demand pacemaker. They've got
And now,
Yeah. Apparently Sandy is jamming.
Yeah.
Whoever Sandy is forgot the mute button. Alright, we'll keep going.
So the pressing wire, the connection between the pulse generator and the electrodes and a cardiac pacemaker. For us, it's the pads attached to the side of the monitor, right? Can you defibrillate somebody with just the combo pads?
Yeah.
Okay. Can you pace them with just the combo pads? No. You got to have the limb leads on to be able to pace somebody.
Like the machine won't work at all.
Hmm.
The machine won't work at
You're
all.
not going to be able to pace them.
Okay.
We have had instances where they were trying to transcutaneously pace a patient. They didn't put the limb leads on. Hooked it up. It wouldn't work. They put another set of pads on. They put the limb leads on. It's like, this thing needs to be evaluated. It's not working. And they, send it to the manufacturer to get it checked out. It's perfectly fine. Did they put the limb leads on? Because it doesn't even show where they attach the limb leads. It shows up. Well, that was a little bit of an issue for that person after that. So, but we have to have the limb leads on. It's a generator with leads. It creates a pulse. Whether it's atrial or ventricular, whether the patient already has it in place. Most of the time, for us, it's only applicable to transcutaneous pacing. Okay, it's best to put it on the anterior and the posterior. There's a better connection. You're gonna get better electrical activity into the heart, causes it to depolarize. That's something with I don't really like promoting any, LIPAC or Zoll or whatever, but that was one thing with Zoll was they made the claim, that they could get pacing electrical mechanical capture at lower amplitude with their device. I don't really know, but that's what they said. I've used them both. I didn't really see that it was made that big of a difference. Pad placement, and patient makes more of a difference than anything. Your assessment skills, your knowledge, how you treat your patient is going to be the biggest factor. Atrial ventricular paste. I think I've already showed you these. Atrial ventricular paste, AV paste. This is for ventricular pacing, or I'm sorry, not ventricular pacing, but intraventricular pacing. So a failure to pace would be that the pacer didn't generate an electrical impulse. That would be you didn't put the pads on, or you didn't put your limb leads on correctly. Oversensing. Whenever we're pacing and we're looking for capture, okay? The synchronous mode is what we usually put it in. Ours, depending on which one it is, leaves demand or fixed. Okay, demand is going to be synchronous that you've got to set it right at 80. If the patient has an underlying intrinsic rhythm of 40, then it's gonna pace it 40 times a minute to get you to 80. If you have it set in fixed, it's gonna 80 regardless. Okay. That can cause some issues as far as causing an ROT phenomenon. And you're hitting at the repolarization phase whenever You know, we're discharging the heart when we're pacing.
And that,
You're pacing at 70, it's discharging 70 times a minute. It's got to relax on its own and we feel, right? Well, if we hit on that repolarization phase, that's when we will cause an on-key phenomenon.
oh, no, that's fine.
For the patient or patient.
I'm not talking to her. I'm going to go home though.
Let me stay over there.
Yeah.
Yeah,
Yeah,
might
why don't
as
you sit
well.
right here?
Just want to get your steps in for the day.
Right.
Sensitivity, this really deals more with intraventricular pacing because our sensitivity, when we set that thing, it's just like the transcutaneous pacing. Okay? Except for, we're going to set a rate, we're going to set a milliamps, but we're also going to set a sensitivity because it can pick up activity that's not there and think that the patient's trying to generate a heart rate when they're not because of movement, especially like driving down the interstate that's pretty rugged. You know, it'll try to start firing when it shouldn't be. So when we change the sensitivity, the lower we set the sensitivity, the more sensitive it is to pick up anything versus so that a higher sensitivity will make it actually look for the patient's heart rate. Mess my clicker up. Output. So what are going to be our indications in the field for pacing? Obviously bradycardia. Okay. But what things are going to cause our patients to have a heart rate that are going to require pacing? Third degree block.
Would be Movitz 2 and a third degree block.
Movitz, yes. Okay. Medications. What kind of medications? Beta blockers. No. Let me give you a scenario. You have a elderly gentleman takes his dog to the vet. Okay. Gets a flea and tick bath. Brings him back home. Playing with it. What is flea and tick bath? Having organophosphates. Okay. It absorbs through the skin, right? Playing with it. It's all in here, all in here, all in here. It absorbs. What does organophosphates do? Overstimulation of the parasympathetic nervous system, right? Sludge.
Sludge.
Right? What's it gonna do to his heart rate?
Tank it.
Drop it. Okay. He ain't took anything. He hasn't, done anything. You do a 12 lead on him for a cardio, but you get a history from him, you'll find out what happened. But he's bradycardic, you can't figure out why. We're trying to pace him. That's where your atropine can help, obviously, 2 pound chloride, whatever, but getting a good assessment on that type of patient. We're going to be pacing him, and epi's really not going to help him, especially when he starts circling the drain because of toxic syndrome he's going through. With Parkinson's white, that's a reentry mechanism. That can cause, it can cause a bradycardia, but it is going to be more of when they have the episode that we would see something like that. Before there will be an tachycardia until basically their heart rate times your stroke volume equals your cardiac output, right? Well, they have a short circuit that's just firing away until they pass out. Well, once they reset, they'll be bradycardic coming around, through that reentry mechanism. The same thing with hypertrophic cardiomyopathy. That's something you've heard about the athletes playing basketball, whatever, and fall over or have a syncopal episode. When they do, they come around, nobody knows what's happened. When I talked a while ago about that ventricle, growing this way versus this way, well, it's working harder and growing inward, so the tank can't feel with blood, to eject that blood out, keep you perfused. So their heart rate's increasing, but they don't have the stroke volume to be able to maintain homeostasis. So they have a syncopal episode. They can be bradycardic. That would be something that you would probably see more in a pediatric patient, okay, versus an adult. But if you had to pace a child, that would be a reasoning for it. And then there's many atrial and ventricular septal defects that you could run into with a kid that you would have to pace them for. More than likely, that would be something that would be a transfer from one facility to another, and there should be a pediatric neonatal team there to take care of it. But the initial call is going to be at the residence, right? And that's where you're going to be playing the biggest part whenever you get there and this kid's got a heart rate in the 30s. Why? You know? Make sure you use the right size pads, okay? At what point are we going to say, I'm going to use the adult pads on a pediatric patient? Or what size child are we going to say, okay, you're in the adult category?
And it sounds of puberty.
Any signs of puberty? Okay.
Off the Broslow tape.
Longer than a Broslow tape or color, what's the correct term now? Length base, yeah. Yep, greater than 49 kilos or at least 15 years of age. I've seen adults that were probably smaller than some pediatric patients, and I've seen 11-year-olds that weigh more than me and probably as big as me. So, size. Because when you think about it, the electricity, it's gonna use the electricity that it needs. Okay? And if they're kind of thick chested, they'll need a little more juice, right? Anterior posterior pad placement. Has anybody in here ever done a dual sequential defibrillation? Do it here and here and here and here. Yeah. For pacing purposes, anterior posterior, across the heart. I have access to a lot of Zoll stuff because that's the monitor I use there at Air Care. So that's the only reason that's on here. There's other, and we get the lock back if we need to, but on the side of my monitor is you'll see how to pace. Okay, in case anybody forgets, apply the pads and ECG electrodes, mash the button, set the rate, set the mode, and hit start. Pretty simple, right?
That's sad. They had it done in person that bad.
That's another conversation later. But there's instructions on your monitor how to do it. Okay. If a certain person would have read the instruction manual, they probably wouldn't have went to the unemployment office. Here's another indicator that's on the little flip sheet that comes with the machine. Shows you how to do it again. It shows you what the pacer button looks like. Bring up the menu. Confirm mode and pacer rate. So is it demand or is it fixed? Okay. And we're going to set a heart rate. Most of them default at 70. If you want to go to 80, 90, whatever. Okay. And then your toggle switch to start. And then start the pacing for the output. We want to make sure we have what kind of capture here?
Mechanical.
Electrical capture here. And once we've confirmed electrical capture on our monitor, whatever, then we'll get our mechanical capture. And how we're going to confirm mechanical capture?
Heart
tones. That is the most definitive way. You know. And then those toggle switches, right there they are on the Zoll X series, what I use to increase your amplitude. Y bizarre complex after the pacer spike. Q have opposite polarity following that. If it depolarizes, it's got to repolarize. This is one that's being paced with 12 lead. Loss of capture. What'll make us lose capture with our machines? Movement. Knocking a lead off. For me, whenever I'm pacing somebody, that it's got where you can look at different leads to get a better view. You may not always be able to get electrical capture in lead 2. So switch to lead 3, switch to lead 1, wherever you have to get the best view, get your electrical capture. Okay. And anytime somebody rips a wire off, you will lose capture. So if you are pacing somebody and they are dependent on pacing to stay alive, make sure you tape your limb leads in place. Okay. However you have to mark it, so that it don't get ripped off and you lose capture, because once you lose it, you may not get it back. Fair descents. If you're pacing in a demand mode and you can't get electrical capture, go to fixed, because then it's going to fire whatever rate you set it at. Understand, son? I don't detect the patient's myocardial depolarization, high sensitivity. That's if you are on intraventricular pacing. There's no native P wave, and the QRS won't deliver a pacer spike. It's pacing asynchronous. Better to capture. That's where we've not got electrical capture yet. So mechanical capture is really going to be irrelevant until we have obtained electrical capture. All right. So we're going to transfer a patient from one hospital to another. All right. And they're pacing with their machine. So they're in a demand mode. What we're going to do is we're going to put our leads on, our pads and our leads on the patient. We may have to manipulate the combo pads a little bit depending on where theirs are placed. We're going to get ours ready. They should have, theoretically, already have capture, electrical and mechanical. Okay. While continuing to pace with their machine in a demand mode, we're going to set ours in the demand mode with the same milliamps as pacer number 1, all right, and a rate 10 beats per minute less than theirs. So if they're at 80 milliamps or 120 milliamps, that's what we're going to set ours at, but we're going to set our rate 10 beats less, okay? Then I'm going to turn their pacer down below mine, all right? Once I have done that, mine should take over, all right? If I have mechanical capture on mine, then I'll go back up to the rate that they were. If I don't, there still has the capture, okay? Electrical and mechanical. So I'm not able to switch over, and I'm going to troubleshoot and see why my machine didn't take over, okay? So same milliamps, rate a little bit below, and then flip-flop them. Drop their rate below mine, and mine should take over, okay? And this is in the demand mode, not fixed, okay?
So if they have the anterior and posterior placement of their pads, how are you going to put your pads in the same position?
That's why I said we'd have a little manipulating on our pad placement, maybe close, until we switch them over. You go as close as you can. You know, if they're right here, then I'm going to go right here. If they're right here on the scapula, I'm going to go paraspinal. You know, so I'm just beside of it. Okay.
But you're not moving yours after you get yours.
No. Once I get them, because this should only be for this shouldn't be a prolonged period of time, really. An hour at most. your transfers, your inter-facility transfers, about how long are they? If you're taking one from,
An hour to an hour and a half.
okay, that's as long as you gotta do it. But that's
Then when
how,
you get to the other hospital, you do the same thing again.
yeah, or they may drop a interventricular wire, so they'll be pasting directly in. You know, like swans, you can paste to a swan, or they may just put the wire in there. It takes just a few minutes. Then we put in a interventricular wire, so then they got a little box out here where I can turn up my milliamps, turn up my rate, sensitivity. It looks like that.
Yeah, good question.
Have you ever had that, like when you're going to transfer a patient, have you ever not been able to get on your monitor to capture from, like, be able to make that transition from one monitor to the other?
No, the last one, the patient was hyperkalemic, and they never treated the hyperkalemia, and they never got captured. They didn't have electrical capture,
Okay.
so I started from square one. You know, I gave my grandma calcium chloride. I put my pacer on. I've got electrical capture. I got mechanical capture. Let's go. But most of the time, you won't have any trouble making the transition. They may not even have.
As long as they have electrical or mechanical capture on there.
You should be able to do it safely that way. We've done a couple trials to figure out that particular sequence of the way we should do it. I said we should do the rate and change the milliamps, but Dr. Whalen, he's an electrophysiologist, and he's like, no, let's do it this way. And we've had the best success with that.
So I don't know how the Zoom thing works, but it said that somebody, like iPhone, raised their hand. I
Yeah.
don't know if somebody on the thing-a-do has a question,
Okay.
but I just didn't want it to get
Okay.
missed.
Remind me. All right. See if they had a question.
Yeah, I had a question. The audio dropped out for a minute. Can you hear me?
Yeah.
When you were talking about putting your pads next to their pads, that's only if they've got capture and they're actually pacing. If they're not pacing, it doesn't matter if you rip their pads off, does it?
That's correct.
Right.
All right, I just wanted to check and make sure I understood that part.
That's only for making the transition. When they're pacing, when you arrive at the outside hospital and they are pacing the patient and they have electrical and mechanical capture, then you put your pads next to theirs and turn your machine on and start.
Okay. But if for some reason, like say, if their calcium's low or whatever, and they're not capturing, there's no reason not to pull their pads off.
No, just pull their pads off and start over.
All right, thank you. I appreciate it.
Mm-hmm. This is what my machine looks like when I'm on the truck or on my helicopter truck, whatever. I just plug this in and make my adjustments here. There's a atrial and ventricular pacer. Okay, that's a guide wire that's dropped in, sitting right in the heart of the patient. Okay? If you transport one of these, okay, you shouldn't be making any adjustments, right? Because you shouldn't have to. But if you do, the only things as far as having to make a change will be the rate, the sensitivity, or the output. Okay, and you'll plug them up. You know, put your limb leads on and watch it. And if you see, anything that we talked about, like fair to sense, fair to capture, stuff like that. It's battery powered. Check the batteries or whatever. It'd probably be you were just going to transport that to that line facility, and then you'll probably bring it back. This is when we're just testing one. We're going to put them on our box. or our machine to take them in. Since whatever. Go to advanced. Everybody good so far? Question?
My issue is, when I'm bringing somebody in Taysom, the ED is such enough tizzy, they rip my shit up, they rip my stuff off, and
Right.
before they even get theirs on.
Right.
And then, you know, you like, slow down.
Right.
You gotta do this right. But,
Well,
it's just like a cluster.
Sign here for.
Like a monkey making love to a football.
Nice way to put it.
I mean, and I've also seen this happen. One of the hospitals up near me, they have one physician that comes in, and whether you bring a patient in on CPAP or there's even having pacing, cuts it off, rips wires just straight off, and I'm like, why? They're dying now.
Yep. That is really, really annoying. And depending on where you are when that occurs, you know, when a physician, you know, they're told, well, like at Baptist, there's a lot of the baby docs, okay? Well, before they ask any questions, they just start ripping stuff off. Well, listen to my story first, you know, let me explain to you what's going on before you go to, you know, ripping and tearing just to get yours put on. Because sometimes whenever you have a patient, you're already maxed out on what you can do with your pacer to keep capture. They have the same thing sitting right there until they drop them and trip on a wire. They can't get them back now. Now we're cutting. Well, if you just took 2 seconds to listen to somebody, you know, if you have to, let across the patient till you get your story told, and then it's on them because it's videoed. We're going to talk a little bit about conduction because we're going to talk a little bit about hemi blocks and stuff. We're going to talk about some conduction things. We touched on it when we were talking about an LAD occlusion. But a conduction is going to be a big thing for us in heart blocks and pacing and medication administrations. So the basic concept of electricity in an EKG signal is an impulse travels towards a positive electrode. It's going to make a positive deflection on the EKG. And the normal direction vectors electricity to the heart. It goes in several directions, but mainly it's going to go in one direction. Right shoulder, left leg, right? When I talk about a hemi block here in a little bit, it's going to be a block of one of the fascicles of the left bundle branch. To get a normal conduction, you only have to have one of those. If it's a left bundle branch block, then both of those hemifascicles are out of service, right? The right bundle branch is the only one that is getting an electrical signal through the heart, causing it to depolarize. That's why blood supply and knowing where the blood supply, what coronary artery is feeding that particular portion of the conduction system. Okay. The right coronary artery, all right? It becomes the posterior descendant, like for no reason at all. Starts out as the right coronary artery, and then as it goes around to the back, it becomes the posterior descendant, all right? It feeds the SA node, the left posterior hemifascicle. It feeds the right ventricle, the atrioventricular node, the left posterior ventricle, and the left ventricular walls. Okay. We'll talk about this in a little bit too, but depending on if you're right coronary artery dominant, left coronary artery dominant, or both of them, which 20% of the population, they're neither right nor left coronary dominant. They're use both vessels. Okay. I'm just out of the center. Okay, good. The LAD feeds the left ventricle, anterior and septal walls, the right bundle branch, and the left anterior hemifascicle. This is just the blood supply that feeds the heart as well as the conduction system. Okay. The circumflex feeds the left ventricular lateral wall. The posterior fascicle has 3 blood supplies, right? One is from the LAD because it feeds the entire left bundle branch, right? Well, it splits off or bifurcates into the anterior and the posterior hemifascicle, but it also, the posterior hemifascicle is fed by the right coronary artery and the left circumflex. So basically, your 3 main arteries feed the posterior hemifascicle. All right. And 10% of the population. All right. The left coronary artery or the left coronary dominant. I've heard some people say, well, it depends on if you're right or left-handed. If you're right-handed, you're right coronary dominant. If you're left coronary dominant. I don't know. I think more than 10% of the population is left-handed. So, whichever one feeds your AV node is the determining factor of if you're right or left coronary dominant. And this really applies whenever you have a patient with a RCA occlusion and they have a heart rate of 30. Okay, their SA node is not getting fed. What you will see, the SA node, it's our primary firing pacemaker in the heart, right? The SA node actually has a artery that feeds just it, sinoatrial node artery. All right, as you know, the older we get, we build up atherosclerotic plaque, okay, in our vessels, okay? The sinoatrial node can actually spasm because it gets ischemic and cause a sinoatrial node infarct, okay? You've heard of sixth sinus syndrome? That's basically what you're going to see. You're going to have a heart rate of 70, you're going to have a heart rate of 90, you're going to have a heart rate of 40, you're going to go in a first degree block, second degree, a heart rate of 70 again. You're basically going to know it because before you have a chance to intervene and give some pharmacological intervention, they've already changed, started into another rhythm. So you'll have to sit on your hands to keep them to do something, but that's what's going on. Yeah. Just like, green light, red light, whatever. This is kind of how P waves up here is atrial depolarization to your ventricular depolarization to your ventricular repolarization. I drew this one, by the way. I don't know if you can tell. It's like chicken scratch.
You do that one?
I do.
That's really good.
I do a lot of drawings. I have a lot of spare time.
I got sick people.
Nothing else to do. I have a couple of bigger ones. It's hard blocks. So here's the first screw block on 12 lead. Can you see that okay? It's kind of older. Can you see that okay? As far as the only thing, the heart rate's 50, but my point was greater than 200 milliseconds. There's a type 2 on 12 lead. The P-to-R interval prolongs. How many eyes do you blink with? How many eyes do you wink with? Wink. One. Blink. Okay. A winky block is one. It's dropping one beat. That's how I remember that. Type 2. The P-to-R interval is always going to be constant. Okay. It's just going to drop a complex. This one is why it's going to be harder to, if you have to pace them, okay, to be able to get captured, okay. You can give them atropine and slow their heart rate down, so you have to pace them. So either way. And here's a complete heart block. If you've seen this 12 lead that said heart rate of 0 up here, what was that? Huh? No, if it said on your 12 lead, it just said 0. On the 12 lead?
What was your question?
If you seen 0 up here, does my ones show?
Zero for what? A
Like,
heartbeat?
see, like right here, heart rate of 50.
Uh-huh.
If that said 0,
It's not capturing the heart.
well, you can look at it and tell it's got a heart rate of at least 30. We've got one in the 6-second strip. We got 1, 2.
Low QRS voltage.
Yeah, you do have low voltage. But in the 6-second strip, there's 8 P-waves. That's where our paper I was showing you. Look at the paper. No. I mean, we're just gonna count our waves, but our rate's gonna be at least 30. You know. How about a trifascicular block? Has anybody ever heard of trifascicular block? Okay. This one, you can probably go ahead and put the pads on them because they're probably gonna need pacing here shortly. All right. This one has a 1st-degree block. All right. It also has a right bundle branch block and an anterior hemi block. Okay. Can we have a left bundle branch and a left anterior hemi block? Can we have a left bundle branch and a left posterior hemi block? No. If you're blocked upstream, your left bundle, it doesn't really matter about the axis. If you have a downward deflection here, it's like I'm blocked up here, so everything down here don't matter. You know, I've got a left bundle branch. Well, anterior posterior hemivascular out. So your axis won't make a difference if they have a left bundle block. Okay. So this is a trifascicular. This one's a 1st-degree with a left bundle branch, and they meet the criteria for an anterior hemi block. It's still a trifascicular. Non-STEMIs. We can go pretty in depth in this, but these are some considerations that we're going to think about on our 12 lead that can be thought of like a STEMI equivalent. Okay. No, they don't have ST segment elevation, but the likelihood that this could progress into something more is pretty good. We talked about AVR a while ago with left main occlusions. Left main or 3-vessel disease, AVR, and V1. If AVR is elevated, usually V1 is going to be elevated as well. 8 surface leads with ST depression. Okay. What else can ST depression mean globally?
Ischemia,
Ischemia,
posterior.
posterior MI.
That could mean that there's an MI coming. It could also mean that it's a sign of an MI coming.
Yeah, it's brewing. How about if you had the same EKG, let's say 8 surface leads with ST depression or inverted T waves on a trauma patient that had a pretty substantial amount of blood loss?
Hypovolemia.
Hypovolemia.
Shock.
It's putting such stress on the heart, you know, because of our circulatory volume that's been depleted. Hypovolemia will cause something similar, but not on 8. Not on 8 leads. Inferior basal MI, so V1 through V3, if you have at least a 0.5 millimeter of ST segment depression, so at least a 0.5 millimeter in V1 through V3. And V7, 8, and 9. Usually it's ST depressed in V1, 2, and 3. We're going to look on the back side. Okay. 15 lead. We're going to look and see. You can do V4R, which will tell you a little bit, but you need to do 7, 8, and 9. And you need at least a 0.5 millimeter. That's a true posterior wall.
Can you go back to that other slide? Okay.
These are some of my illustrations for that article. Welland syndrome. Somebody ever heard of Welland syndrome?
Nope.
Okay. Welland syndrome, Henry J. Welland's come up with this. And you see this progressively symmetrical, deep T-wave inversion. Okay. There have been several studies on this particular morphology of EKGs. 20% of these patients had 100% occlusion of an artery. Okay. 20% of them had 100% occlusion of an artery. Okay. 75% of the people in this very same study had an MI within 1 week after this was noted. Okay. The problem with this is they may have no chest pain. They have no shortness of breath, because 20% of all acute MIs, their only complaint is unexplained non-exertional dyspnea. They're short of breath and don't know why. Okay. Get them to the hospital. They're having a huge stimmy. Okay. But this particular one, their cardiac markers will be normal. They have no chest pain at all. You may just be doing a routine exam on this patient. It may be the shortness of breath or whatever. You see this, but they'll have no pain, no chest pain. Okay. One of the pilots that flies for us, he had this. They have to have a full physical exam every year. It's their yearly. Okay. He went in and got an EKG. That's what they found. 2 hours later, he's in a cath lab. He had 96% occlusion in his LAD. He's very athletic. Like him and his wife plays tennis every day. He runs. He's a former Marine. He exercises every single day. He had no pain, no nothing. Just went in for his yearly. That's what they found. Okay. If you'll notice this one and several other ones, whenever you have some abnormality, whether it be the T-wave inversion, the ischemia, the elevation and depression or whatever, in V1 through V4, it's always a concern of some sort. Okay.
You're saying progressive T-wave.
Yeah.
Progressive symmetrical. Is that like it just gets larger from V1 to V4?
It can be that. This one is not as good of an illustration as maybe this one. You see how here, how it goes up and then comes back down? And
How
this
do you
one,
tell the difference in that and just an inverted T?
look how it comes, how an inverted, do you see how, so it goes up your R,
It
S,
makes
and it
almost like a
comes back.
sinkhole.
Yeah, it progressively comes up and then comes back down. It comes above the isoelectric line and then makes a sloping, like a 90-degree sloping to the T-wave. See? I might have another one on here. See this one? How it comes up, makes that big inversion of the T-wave. This one the same way. It comes up. So that's concave and not convex, but it comes up. About a 90-degree angle, comes back down, and inverted T-wave.
And so it's going to come down
You
at
got
90 degrees.
ST elevation.
No, that's this is
Concave.
concave and not convex right here. And the way it comes back up. This is Welland syndrome. Your R wave progression it stays preserved, because once you lose that, it's actually going to be a true anterior wall MI and not Welland syndrome any longer. Okay.
And so it's always going to be diagnosed in V1 through V4.
Yes.
Okay.
Because you're looking at the LAD.
Okay.
And that's the big thing about like this one in D winners. We're going to talk about D winners in just a minute, but you'll find them in V1 through V4. There'll be an abnormality there, and the only issue is they won't have any like real symptoms. You're catching it kind of early. Is basically the thing here. Here's the D winner T waves. Okay, you can find it through V1 through V6, but mostly it's V1 through 4. Okay. See how when it comes off here, off your R wave down to your S, it comes up, slopes up, and then to your T wave. There will be at least a millimeter of concave ST depression, greater than a millimeter at the J point. Here's a J point. It's concave. This is my illustration, so it might have should have been a little more curved here and up. That's what one looks like. That's concave. This is a D1 or T wave. LAD stenosis. You transmit this EKG to a cardiac center, and they're going to take them to the cath lab. It might be urgent versus emergent, but they're not really gonna sit on them and let them brew for long.
You said stenosis of what?
The LAD, like with the Wellens syndrome, and in the particular study, well, there's been many studies, but like an overall, 100% of the patients had some form of stenosis, but 20% of them had 100% in LAD. Okay. And then 75% of people that they find it in will have an MI within a week or so. Okay. But if you take a patient in with Wellens syndrome, they will take them to the cath lab. All right. DeBakey dissections. When we do a 12 lead on somebody and they're really hypertensive, okay? They have a history of hypertension. All right. We do a 12 lead, we have ST elevation and 2, 3 and AVF. All right, that's our right coronary artery, right? We're going to do V4R. It's going to be elevated. We're going to do a posterior MI, V7, 8, and 9 are elevated. We have proven we have a lesion in the proximal right coronary artery, right? Yeah. Check a blood pressure in both arms. But normally a proximal right coronary artery occlusion, which would say right ventricular involvement, would that really be hypertensive? No. Could they have a history of hypertension? Yes, but they will be hypertensive. Okay. And what has happened is the vessel lumen. Okay. If you think about 3 garden hoses inside of each other, let's poke a hole in the middle one, and as it starts bulging out, as your superior vena cava comes back in, so this right coronary artery is pressing on it. Okay. It's causing the ST segment elevation. So if we treated this like an MI, what would happen to our patient? They're having a dissection. Right. They're going to crash really quick. It can dissect causing it to look like a STEMI, but they need a graft instead of heparin and Plavix and thrombolytics. Okay. Does that make sense at all? If they have ST elevation at 2, 3 AVF, V4R, 7, 8, and 9, they're hypertensive and have a history of hypertension, it's a DeBakey type 1 dissection to prove it otherwise. Okay?
So hypertension and what else?
They'll be hypertensive, they'll have a history of hypertension. And they'll have elevation, basically like I was looking at a proximal RCA occlusion.
So elevation.
2, 3 AVF, V4R, 7, 8, and 9. I've isolated picture right here. It can be either any of these, but this is the biggest one and the worst one. So that's what I'm going to call it, the worst, until I prove it otherwise. Okay. Other tests that we can do, or other vital signs that we can obtain. limbs. Check the blood pressure in their legs. Check it in both arms. Okay. If it's a thoracic, it's going to affect their legs. It can be in either arm. This one right here can actually cause STEMI, ST elevation MI, or to look like a STEMI. And it can also cause stroke-like symptoms. Okay. What feed your internal carotid feeding your brain, right? Well, this is where it's occurring. So if it starts pressing against that, it can have stroke-like symptoms. S1Q3T3. We've talked about it a little bit already, but you've got a deep S wave in lead 1. All right. Got a pathological Q wave. It'll be wide, deep, whatever, and an inverted T wave. Again, patient assessment, like what we talked about. Have they been bedridden? Have they been immobile for a while? Do they have a history of cancer? Are they pregnant? Is there any reason they could be hypercoagulopathic? Okay. We give them oxygen therapy. They're not improving. They don't have any history of pulmonary issues, no asthma, no COPD, nothing. They should have perfectly healthy lungs. Well, they have wheeze and rails. They obviously don't have a history of heart failure. It's PE to prove it otherwise. And they can have a PE without this. This is sensitive. It's not necessarily specific to, if you see this EKG, they're having a pulmonary embolism. Okay. It's just something that is found quite often. But the EKG can tell us if they have pulmonary issues. Okay. Ischemia, inverted T waves, the right ventricular strain patterns, the right atrial enlargements, because that's the right side of the heart going to the left side of the heart. Well, there's obstruction of flow from the right to the left. S1Q3T3. Remember the 17-year-old I talked to you about? That's his EKG right there.
And just so I remember correctly, the pathological Q wave is the one that's the 1/3 the depth of the R wave, right?
Yes, it is either 0.04 milliseconds wide, or it is 1/3 the height of the depth of the R wave, or the QRS complex.
Q channel.
Yep. Ironically, I ran that kid just a few weeks before in a wreck because he was driving. You notice the only one in AVL is the only thing that doesn't have an inverted T wave or depressed. Got it in 2, got it in 3. V1, 2, 3, 4, 5, 6. So, is everybody good? Or you need a break?
I'd like to have a break.
You
Yeah.
need to.
I'm tired of talking about that.
How about when you said 17-year-old PE? All right, okay, bro.
Yep.
You didn't draw that heart.
That's where it
How are your other drawings look really crappy?
Oh, that's probably when I first started drawing. Well, yeah.
You smoked it.
That's the cover of the book I drew.
Good job.
Oh, that's some better. Here's where I drew the corner from. Pulmonary circulation. That's what I'm doing right there. That's what I'm doing.
Oh, okay.
Struggle bus.
Good job.
Struggle bus.
Driving it. Oh, yeah.
That's nice. Yeah, that's a good one. Yeah, well, I want to be an illustrator, medical illustrator. Oh yeah, that's a good one.
I'll do several hearts. I have to stuff, so
Yeah, yeah.
should be trying to color them.
Please don't put on there, I'll do about 8 hours working.
Yeah.
You had to buy it.
From what?
Yeah.
I may just take
Oh,
Just
yeah.
got
I
a new
would-
phone, so I lost my old one, so I don't know
You
anything.
would.
it. Yeah,
I thought that was gonna start selling at one point.
I thought it was the.
Cause I mean, are
Yeah.
you
I was doing a pizza studio and he had one in his box and I said, I'm taking that.
I need to do my
Or
piece
sell them
trio.
there. That's the one. I have the-
Oh yeah, yeah.
I'm
Yeah.
one step at a time right now.
Well, good job.
Yeah.
Way to be somebody.
The last peach tree that I had was like 2013.
It's been a day or two ago.
You do it all with pencil.
I did the one here last year.
Cause cause it was right after my.
Do you have
Yeah.
what's that book?
Cause I got my initial
medical illustrator.
paramedic in 2007. I had it then.
It's not
in
an illustrator book.
2013.
Yeah, 'cause you won't find
Yeah.
TLS classes anywhere. Pretty
And I
much
mean-
most places.
I meant to take it the last time he had it here, but I didn't get to. But I'm glad there's gonna be a critical
Here's
care
one I do
class
for
here.
Oh yeah,
The only thing is why.
the valves.
You already
and
have
the-
your stuff up.
Yeah.
Back on it.
them.
I need to get, I want my
Look at it.
SSC, but I want to get, I need to get.
So it's a little different.
Yeah.
Yeah, that's what I was going to ask you about.
Yes, they're required that you do.
Oh, yeah. I was gonna say, I was
Or they're
good.
gonna send you back.
Right.
Because when I talked to Louise, last time, she was like, yeah, she's, you don't go through the business program.
No, no,
It's like EMT. I'm working this one back.
Yeah.
The netters.
Well,
Netters.
it's actually-
Do you have-
Well, that's why I called it.
Netter is?
I called something, I said, like,
Oh man,
I was like,
that's
I
the one
want
that have
to get
your
mine done
dolls
in a
and
row.
stuff.
Yeah. Because the only reason I didn't take it the last time we had it was because it wasn't.
What?
I didn't want to have to go like I don't mind doing it in its consecutive days. It's
I'll
gonna
talk
be,
to,
but with this.
It's gonna be on
care class.
Flynn's
It's
going
Monday or
to
Tuesday or, you know,
post
Thursday
it
or
to his
Friday.
YouTube page. All these lectures.
This
I mean, it'll
or maybe
be.
maybe I was with the fire department.
I'll try to put it back in my car a little bit.
I think so. It's in May.
I'm willing to drive. We're back.
Yeah, he said he stopped by years ago.
You don't do the critical care.
Forward.
Put me in the coordinator.
PowerPoint.
Oh,
I'm not sure who's doing the coordinator now for it.
I'll have to square back.
Yeah,
I'm not
I mean,
sure if I know anybody.
Yeah.
that's what, I studied better.
Yeah. I'm a.
Yeah, I'm a hands-on.
Yeah.
I was making sure, I know your most, I know your UMBC program, the only two places you can get it is Navy Tech or lower.
Yeah.
They have done some of them things that were based on a shift schedule.
Yeah.
Because they did them three,
Yes.
they did them like every third day. Where people work shifts could go. When I did mine, I took it in Pinehurst, way back.
Good.
Oh, that's where I did my,
It was
interview.
one of the few places that had it. Took it 2 straight weeks.
I don't know, it's like, I can tell her right now, like, going to sit before I take that class.
You're gonna have to what?
I don't know how to get a sedative before I take that class.
It's a lot of information in a couple weeks.
Mm-hmm.
How long will this one be for? How long was the last one he did? Like, I think it was like 4 weeks.
Yeah, he stretches it out pretty
I
good.
mean, and you gotta look from me being where I'm at,
Where you live?
Annapolis.
Oh, you're right there by me.
Yeah, so we're not as familiar with events, pumps and everything that you get arrested on.
I live right there on Miller Creek.
Hmm.
I took the PEDS critical care at UMBC.
Okay.
Their very first class.
Wow.
And then the actual certification process is done where?
There's depends on what, are you just talking about, are you talking about taking the actual certification exam? It's offered through, say what it does, FPC.
Look it up, or you can find it over on, IASC.
I never took it, didn't see, they have a name for that thing.
Was it stupid crazy amount?
It's like $307.
It's like the cost of the class. Pretty much.
Yeah, it's like $400 now.
Just
That's crazy.
Wow.
They charge you the same for cert, pretty much.
Oh wow, really?
That's if you're doing the FPC or CCPC.
It's a money right.
I mean, you get a membership, and I
Yeah.
think they give you $80 off each exam.
So the first step, passing class. Let's just tackle that first.
Everyone from over there. Yeah.
What we doing right now? Peanut butter pie.
Where'd that come from?
I would like
Degree,
peanut butter pie.
goodbye, Walmart.
Big one out here, when she's- He listens to me.
Take care of our
She lives too far to drive me here. My bad now. You're so pretty.
That's the girl enough for lots of it. I went ahead and blew it in bad as they didn't even care about it. I said, okay. I love you, I love her too.
It's kind of like a knocking engine.
Yeah.
It's gonna blow in a minute, but it ain't wet yet.
Was talking about the proper read place. It was John's walked in. Basically, what was fire department said, here, I haven't seen anything on 12 lead cancer 12 looks perfectly fine. Like, okay, so I wait took mine up to get in the truck. Got the truck, went to took mine up, and his leads were down here.
That's just not gonna work.
Well, that's kind of the way it was, because I took up the load. I'm like, let's boot it up, and I booted it up. All that crap shows up.
I had a patient that I went to confirm a death. And I'm talking DNR, hospice. I'm going to say they're dead. And he was on there pumping a blood pressure cuff up like to hell. I can't get a blood pressure cuff. I can't get a blood pressure on them. Well, they're dead. I mean, we're a system. We were like, I could have took a ruler and drew a straighter line.
Look, here's a picture of peanut butter pie. Look at that.
You want to different to make sure, right?
Peanut butter pie is fine. Whatever kind of pie you're designing.
Oh, I'm glad we got that.
Yeah. Well, there's a lot of pies I don't like, so.
Oh, I'm buying, but not all of it.
I mean, if you buy like banana cream pie, I ain't going to it.
Well, good.
Or chocolate
That
pie,
means I don't have to worry about you.
or
making my
coconut cream
pie.
pie. Or like peanut butter, apple cinnamon. I don't like blueberry. We'll just go with peanut butter, it's the same as.
Station stuff. All right, we can get started back. Just so you have a heads up the rest of the afternoon, Roger's gonna go roughly about another hour, finish up this presentation and maybe, look at just some different 12 leads to see, if anything new stands out to you, that kind of thing. And so somewhere around 3:15, we'll, break again, and then we'll figure out as far as dividing up into stations for those that are gonna practice between that and class ends at 6, as always. So not another hour of your lecture on cardiology.
Down, I got 2 left, so I'll make a decision.
Do what?
I got 2 left, so I'm gonna make a decision.
Uh-oh. He's run out of Pepsi. We may be in trouble.
I catch more hell over drinking Pepsi than anything. Why don't you drink water? It's got water in it. My kidneys are better than y'all, huh?
Did you do heroin?
No, I quit that.
See?
Cost too much. I take enough meth to tranquilize a horse. I have ADHD really bad. And if I don't take my medicine, you'll know because I talk really, really fast. So that kind of slows me down a gear or so. I can take it and go to sleep. It ain't gonna bother me, but some other people, it jacks them up. So we're gonna talk about axis and the way to find your axis. I've talked a little bit about it. An anterior to posterior hemiblock, with your bundle branches, things like that. With your QRS axis, okay? This is a normal axis right here, all right? Lead 1, 2, and 3, your complexes are all gonna be upright, okay? And your QRS axis on your EKG will be 0 to 90, okay? It gives you a numerical readout. I'll show you here in just a minute if you don't know where it's at. That's how you find it. Because sometimes it'll be like, well, is it a positive deflection or a negative deflection? Okay. And you'll be able to read it there. So if it's an anterior hemiblock, I drew that one too. You're up in lead 1. You're down in lead 2 and down in lead 3. Okay. This is a pathological left axis deviation. All right. Now a physiologic left axis will be 0 to -40. Okay. A lot of times with obesity, pregnant women, diabetics, they will have a physiologic left axis that'll be about 0 to -20. Theoretically. Doesn't really mean anything, it just kind of the way the heart's turned because of the size.
Can you not just remember the physiologic by up, up, down with your leads?
You can.
You don't have to necessarily remember the numbers, do you?
No, the only reason I put the numbers on there is because sometimes you may not be able, you may not be able to tell. It may be half up, half down. It's like, okay. I just remember I use both criteria, but it can be either be up, 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 or down, down, down.
Yeah.
Half up, half down, whatever, but the numbers, and lead placement. You don't put it on the limbs, you're going to get a skewed reading. You put it on the chest. So posterior, 90 to 180. All right. This one happens a lot less often, only like 25% of the time. And anterior hemiblock is 75% of the time when we're talking about anterior posterior hemiblocks. This one's a lot harder to obstruct. When is a hemiblock relevant to us? When?
Detox.
We'll get that in just a minute. That's not a hemiblock. That's axis. When is a hemiblock concerning to us?
You're referring to post-hemi or interior?
Well,
Either. Is it either?
As far as which one?
Yeah.
Yeah. Either one. When are they even relevant to us?
When you have a bivesicular block.
Okay, yeah. When they're having an MI, okay, not only do we have an obstruction of flow because they're having a heart attack, our conduction can be lost too, okay? We've got a clot sitting in a coronary artery, when we talk about heart rate, stroke volume. This is our conduction. We don't want to lose conduction in a sick heart, People have anterior and posterior hemiblocks all the time, They walk around with them, live with them every day. It becomes really relevant to us when they're having a STEMI, okay? Because that adds more complications to the picture.
I think somebody had a question on there. It popped up a notification in the corner.
Oh.
I can't really put it down now, but there was a check mark.
Right there. What's that thing right there?
That's them.
Oh.
There's one of the iPhones. Whatever it was. Anyway.
My clicker back. It is now. Okay. This one's VTAC. All right. It's going to be your QRS axis will be 180 and above. Okay. They can have an extreme right axis deviation and not necessarily be in VTAC, but if it's above 180, it's ventricular in origin. Okay. One thing I do want you to remember though with this is pediatric patients will have an extreme right axis deviation anyway. Okay. Until they get older. I wouldn't worry about axis on a kid. Okay. It's us older people that are having heart attacks from poor eating habits and drinking too much Pepsi and all that kind of stuff. But you can have a patient with an extreme right axis, and like I said, it may not mean they're in VTAC, but that's what I'd look for, And usually, and the rhythm is ventricular in origin here. All right. And they can also be in VTAC and not necessarily be have an extreme right axis deviation. I'll show you one here in just a minute. Here's some mimics. Benign early repolarization. Okay. J-point notching. All right. Right here. Usually that is seen. I've got about 10 of these EKGs, and every one that has benign early repolarization, you find this J-point notched and B4. You're not going to have any pathological Q waves. You're not going to have any reciprocal changes. There's not going to be any ST depression or whatever in the opposite leads. That's how you know it's benign early repolarization. If you got pathological Q waves and you got ST depression or you got inverted T waves, you probably got a STEMI and not benign early repolarization. Okay. And that can also be looked at as a J wave, whatever. Okay. I get confused a little bit. First time we look. Here's some repolarization variants. Different definitions of it. Here's your classic one, the J-point notching. All right. I'm going to slow it down stroke. You don't have any ST elevation like you go up here. You got one here, but really no elevation. It's basically right at the isoelectric line. Just a little RS-R complex. J-point notching. Pericarditis. We talked about the global ST segment. Elevation seen with pericarditis, this J-point notching. And when I talked to you about the geographical, when you're looking at it and it geographically doesn't match up, you know, like, is it inferior, is it anterior, lateral, because they're in different places. Those pericarditis kind of patients will have J-point notching as well. And this can really be mistaken for ST segment elevation, calling it an MI. That's why if it's global, this is probably what it's going to look like.
So even this one with just the J-point notching going to be all throughout your leads versus
it can be all throughout, or it can be geographically like
sporadic.
Yeah, and your patient presentation, like they have chest pain laying flat. I run a 12 lead. I've got all this ST elevation. Well, I set them up to the semi-Fowler's position. The pain's gone. They're not breathing like a gut shot cat. And I run another 12 lead, and all that elevation's gone. Why? You know, because it's setting in the inflammation down here. You know, and it's irritating it, causing a spasm. And they've got all this elevation. Well, I get it up. The heart's like a pendulum. You know, if it's laying on that infectious process, it's irritated. You know, you get it up off of that. Now there's no elevation. There's one in V4R, benign early repolarization. So you got a little bit here in 5. Nothing in 6. B1, 2, 3, 4 is good. All over here. Does anybody see any elevation? Any depression? Any pathological Q waves? Anything else that is abnormal about this EKG versus this and this? It's benign early repolarization. Hyperkalemia. This is a really big one. Your renal patients, especially dialysis patients, they can have this. And they've heard of peak T waves. I guess every time you hear potassium, it's peak P waves or peak T waves. it can happen. I'm more concerned with their stage renal patient with a wide complex tachycardia versus these peaked T waves, okay? Once it passes 7.5, okay, the SA node can stop the fire of the SA node. When it gets to here, they're about to check out, okay? Yeah, that's really bad. That's a sine wave. They're about to sign off. Yeah, exactly. It will go from this to it's kind of like a clothes hanger. You're trying to unfold it. You're going to get it straightened out. Okay? That's what you're going to do. Actually, a patient that has a high potassium level is a whole lot harder or is a whole lot easier to reverse than a patient that has a low potassium level. Okay? Because you can only replace potassium. If you got a central line, you can do it at 20 milliequivalents an hour. But you got a peripheral line, you can only do it at 10. For me to fix this potassium, I need to give them calcium, insulin, sodium bicarb. I can do albuterol. I can do K-exolate, which is not really, it'll work, but not very quickly, and it causes a mess. Okay. I can give that for this to reverse them because when I'm giving the calcium, I'm stabilizing the cardiac membrane. That's the only reason I'm giving the calcium. If you give calcium chloride, it's 3 times stronger than calcium gluconate. So just remember, for every amp of calcium chloride you give, you'll have to give 3 amps of calcium gluconate. Calcium gluconate's a little safer. Doesn't burn the vein quite as much, especially if you're giving it to a peripheral line. If you are giving it to a peripheral line, make sure it's a big one, like an 18 gauge in the antecubital fossa. Or if they have a portacath and you can access it, do it through something very big. Don't do it to a 24 in the pinky, unless you absolutely have to. I mean, you got to do what you have to do, but that would not be the preferred method. There's a good one. It's quite a bit of information on that EKG. We want to say their potassium level was. That's a wide complex tachycardia for sure, right? So, well, so mine is clear over there. Oh, I was looking. So why their QRS is 200 milliseconds. Everybody will call it VTAC.
No, because it's getting there. But it's because of the hyperkalemia.
If you don't fix that, it ain't gonna be long.
It'll be flat.
Mm-hmm. I guess you could give amiodarone there. It's potassium channel blocker. Okay. Here's a one that's about to sign off. QRS is 208. Look at your QT interval, 606. Severe.
Just a tad. Get up, walk it off.
Yeah. I think we're doing all this. Oh yeah. Prevalent QT interval. Regatta syndrome. Anybody heard of this?
Fresh memory.
So Regatta syndrome. You see these little orange lines? This is your cardiac action potential. All right. It's got 4 phases, right? Or 5. 0, 1, 2, 3, 4. All right. 0 is sodium's going in. Potassium and chloride's coming out here. Calcium's coming in here. Potassium continues to leak out here. Potassium rectifiers back into here. Regatta syndrome is a sodium channel neuropathy, okay? That is the whole reason for this. There's coved and saddle, aren't? But you have these funny morphologies like this. This is the brugada, the first brugada that I had. Okay. See the heart rate?
Just say 26.
26. Okay. They're symptomatic. Okay, for sure. You gonna have a hard time pacing this one? Does anybody see a P wave? Okay. QRS is wide. QTC is prolonged. That's going to be one that's going to be. We talked about some of the cardiomyopathies that you might have to pace somebody for. Here's one. You'll see it in V1 through V4. Obviously, with that other one, it's pretty simple to see it. You have the there's the coved. That's usually the one you see the most often. There's a saddle with the ST7 elevation and the saddleback. A little, it's not quite as pronounced with the saddle as this one is. There's your horn and there's your the back. That's a brugada. Well, Parkinson's why. So there's AV nodal reentry tachycardias. Okay. So normally our SA node it's firing how many times? 60 to 100, right? Okay. When it gets to the AV node, a lot of times that's where it gets filtered, goes on down to the Purkinje system. All right. So it may be firing at 90 up here, gets to the AV node, gets kind of filtered out, got a heart rate of 70. All right. With this, with like Wolff Parkinson's White or LGL, long gang olivine, they have a reentry mechanism, which means that it's bypassing the filter. There's some little microfiber in there that's bypassing that. So if they're firing at 140, that's what you're getting, okay? That's why you have this short P-to-R interval syndrome. It's another name is short P-to-R interval syndrome, but it's a early ventricular depolarization, okay? That's the kind of the phenomenon behind it. But it's bypassing the filter. It's basically like a short circuit, okay? Anytime you have a short circuit, what do you get? A surge. You know, like if it was the light system here, it'd get really bright for a couple minutes and then it would shut off. That's where they get into this, you know, palpitations and they'll have syncope episode, okay? And reset. They have a short circuit. All right. This is the one we'll see more with AFib versus long gang olivine is seen more with an SVT. But it's just a strand of microfibers between your SA node. Sometimes it might go into the right ventricle. That's where you see mayhem fibers at. What medication do we not want to give this patient? Cardizem. Okay. What phase of the cardiac action potential does cardizem affect? What phase of the cardiac action potential does calcium affect? Phase 2. We give a calcium channel blocker, it affects phase 2, right? That's why here with them, it's a depolarization. Here's another example. This is my cartoon drawing here. Make any sense though? Anybody? You have a reentry circuit here. Instead of going from here down, okay, with your normal electrical signal, it bypasses it. It doesn't go through here to be filtered. Okay. So you're the short P-to-R interval, you have the delta waves. Digitalis. How does Digitalis work?
Whatever medication in the system.
The what?
Whatever medication.
Digitalis poisons the sodium potassium pump. Right? Okay, if we poison the sodium potassium pump, all right, Digitalis is a medication for heart failure patients, right? Okay. Well, when somebody gets digitized, okay, it takes about 24 to 48 hours once they start taking Digitalis to be able to be digitized. When they take Digitalis, this is a dig wave, and I think like 60% of the patients that take Digitalis will actually have this dig wave. Okay, what happens with Digitalis is it poisons the sodium potassium pump. Okay, they have to have it's called an antiporter, and it basically brings calcium back in. And anytime you add calcium to something, it's gonna work it. Right? So it's getting more squeeze out of the heart is the reason that you're giving Digitalis. Okay, why you want to be cautious about giving them calcium, all right? Because that is what this medication is doing by poisoning the sodium potassium pump there. Gets more calcium back in, get the heart to squeeze, all right? Now, whenever you cardiovert one of these, if you have to, they usually respond very well, like flat, once you cardiovert them, so you can do CPR. But if you have to do it, do it, but I'm just letting you know that they respond very well to electricity. Like best you ever saw.
Easily stabilized.
Yeah, we're gonna stabilize it. All right, we have to start flat and work our way up. So, and it's really crazy. All right, so they say patients that have taken Digitalis that have overdosed can have these green and yellow halos. All right, and that came from this theory that Van Gogh, who was a painter, had green and yellow halos around his objects that he painted, right? Well, not very bright, but if he's seeing these in his paintings, why would he be painting green and yellow halos around them? They thought he had overdosed on Digitalis. If they're already there and I'm seeing them, why would I paint them again? But yeah, they say they'll see green and yellow halos if they have a Digitalis toxicity. There's your dig wave. There's your dig wave. Dig wave. Dig wave. Almost looks like a half a smiley face.
Can you go back to the other side?
That one?
Yeah.
Oh, okay.
For about 15 minutes. Okay.
All right.
I still use Dig.
Yes. It's not as
You don't see that.
no. No, because they have carvedilol supposed to kind of take over. It's an alpha beta blocker. Supposed to work a little better. Anytime you start poisoning different things like aspirin, okay? Aspirin poisons platelets. So you give an aspirin, it poisons. Once aspirin touches a platelet, it poisons it for the life of the platelet. Depending on where you're reading from, it could be 7 to 11 days. Okay, so we start poisoning things like this, the sodium potassium pump, and then they stop taking it. Now we've got electrolyte disturbances and everything else from just this one medication. Okay? Kind of why I don't like any other on. Its half-life is 96 days. You screw up and give somebody amiodarone. I thought it was VTAC. Well, what's one? Well, if you give them lidocaine, that's 4 hours, not 4 months. That's why I like it a little bit better. There's Dig wave. Here's the cardiac action potential. Different drugs and where they affect different parts of the cardiac cycle. So sodium channel blockers, lidocaine, the class 1 antiarrhythmic. It blocks sodium going in, okay? Potassium chloride are leaking out, calcium's coming in, potassium continues to leak out. Here's your potassium rectifier, so it's coming back to its normal threshold. Is extracellular or intracellular potassium bad? Extracellular. If it's in the cell, it's fine. When it's out here running around, that's when we get the hyperkalemia and hyperkalemic arrest. Extracellular potassium is bad. Okay? Intracellular is fine. Okay? Does that make sense? Amiodarone it actually blocks sodium, calcium, potassium, different things, but its primary classification is a potassium channel blocker. Class 2 is where your calcium channel blockers affect the cardiac system. There's beta blockers. That means they primarily affect beta 1 if they're cardioselective. All right, labetalol, it's a alpha beta blocker, but it primarily affects beta 1. All right, do I have to have as much consideration when I'm giving a beta blocker to affect somebody's heart rate if it's cardioselective versus giving them one that's, like a metoprolol? It's not cardioselective. It's going to block beta 1, beta 2. That's why I like labetalol. I guess I like metoprolol, but we're giving these medications knowing their effects, what they're going to block, what they're going to do, how's it going to affect, down the road. When my patient has a heart rate of 160 and they're really hypertensive, I forgot to ask them about their history. Well, now I give them this, well, the heart rate and the blood pressure's fine, but now they can't breathe. Now they sound like, from bronchoconstriction. Is that gonna be a complication? Right.
So is that why, like in paramedic school, they always hammered, you have to pick amiodarone or lidocaine in your VFib arrest. You can't use both because it blocks the potassium and the sodium channel.
Yeah. This is what I want you to think about. All right. When you start mixing chemicals in any fashion, you're creating a chemistry project, right? Well, whenever we give a sodium channel blocker, all right, that's what we're working on. If it doesn't work, then we can switch to something else if we have to. But how is those medications going to interact with something else that I might need to give?
Right. I was thinking like in the presence of refractory VFib, after you've given, say you start with amiodarone, after you give all your amiodarone, could you go with lidocaine or should you not use it at all?
I would, but I would have probably went with lidocaine to start with.
Yeah.
And give mag. I just don't like it. Me personally.
I understand.
And now we're having to go to these different bags and inline filters because it'll precipitate with the plastic and D5. So we had to have an Excel bag they've come up with or whatever medication that interact with it and start particulating. And you're not supposed to give it with sodium chloride. So you're not giving it with D5, but some kind of interaction with medication and the plastic in the D5, the bags of D5. Just is too difficult to begin with. So I've got 100 milligrams of lidocaine, and I've got a bag that I can do a drip with. It's much simpler. And can you give somebody that's allergic to Novocaine? Can you give them cardiac lidocaine? Novocaine or Xylocaine, whatever, that you get at the dentist office. Can you give them lidocaine? Those are two entirely different compounds. One's ester-based, the other's amide-based. And a allergy to cardiac lidocaine so very rare that it's almost unheard of. Now, numbing somebody's mouth for dental procedures, yeah, that happens all the time, but not with cardiac. This is just for heart failure. The difference in left ventricular end-diastolic volume, here's your normal one, and right ventricular end-diastolic volume. Okay? Is it a systolic or a diastolic failure? Okay? Are they having trouble clearing the ventricle? Are they having trouble filling the ventricle? It's right-sided, it's usually having trouble filling. Left-sided heart failure, you've got pulmonary congestion, they're usually having trouble clearing the ventricle. Okay? It should just be 12 leads. Yeah, I think there's just a bunch of 12 leads up there. If not, I'm gonna have
See
to go,
what they can pick out.
I'm gonna have to go dig into my box to get some. I got a bunch of 12 leads. I think I've got about 1,000 EKGs. What's this one? All right, we'll start in the beginning. Is it regular? Even if we look down here in lead 2, is that a regular rhythm?
No.
Okay. All right. Is it fast?
No.
Not really. Is it wide?
Yep.
Okay. Could be. Our QR or QT interval is 606 or 208 milliseconds wide and a rate of 74. So yeah, we're fixing to check out.
That's a sine wave.
Yeah, that was a sine wave, or just about a sine wave. It was just before being a sine wave. What do you see? See P waves? PR intervals normal? QRS complex?
Yeah.
122.
Oh,
Just fits the criteria.
those T waves look a little tall, don't they?
The QRS wave.
It's not a STEMI, but it's close. It's in B1, 2, 3. LAD.
Welland?
Yes. Say it louder.
Welland
Good.
syndrome?
Wellens. What about this? All right, our heart rate 73. PDAR interval is 151, looks like. 381 on our, 422 on our QTC. QRS is 40. So we got up, got a normal axis, got a P wave. That's pretty much, that's the way there.
Is it getting inverted in some of them?
There. Yes. What about Q wave? There's a Q. There's a Q. There's a Q. There's a Q. our EKG is not horrible, is it?
No, but it's not normal.
Right, it's not normal. No. So now what are we gonna do?
Treat our patient.
Praise Jesus. All right. How about this? Get that white thing out of there. That white thing's in my way. Okay, good. What's that?
Pete, Hewitt.
Is it tall?
Yeah.
The wide?
Atrial.
So we got right atrial enlargement so far. Okay. Is there one of those really large P waves for the QRS complex and a T wave?
Mhm.
Okay. What? What do you got?
Oh, no.
Okay. Let's look right here. What do we see here?
Elevation.
You see 2 millimeters there? What about right here? You see a millimeter there? Our QRS ain't quite wide enough for a millimeter spot. We don't see nothing really abnormal. It's not like blasting off the page at us. But our patient presentation fits something that could be concerning with an EKG that could be questionable for different things. What are we gonna do? Transmit it? Let somebody with a white coat on.
Yeah.
Take a look at it. Where do y'all usually go to around here? I mean, do y'all go to Charlotte? Do you go to?
We either go to Fry, Gaston, or Spartanburg, depending on which end of the county you're in.
Spartanburg's PCI center, right?
Mm-hmm. And so is Fry, Gaston.
My buddy works for he used to work for us. He's PA. And Gaston.
Mm-hmm.
But you can transmit your EKGs to them, right?
Yeah.
Okay. Spartanburg it is. What about this? Can we have a P wave for every QRS complex? No.
You got a QTC of 595.
Or prolonged.
Mostly they're in a 3rd degree with a run of VTAC.
3rd degree with a run of VTAC.
I mean,
I like it.
it doesn't make any sense, but.
Yeah. But you could, aside from that, you have some ventricular irritability, right? Yep, and our QRS is 163 milliseconds wide. And we're fast. Okay. We got a block here, but got a downward deflection.
Give light, can you see what's left?
Yeah. We can stabilize it. Yeah. So we'd want to know a little bit more like a history. Do you have a history of renal disease? You know, have you had dialysis lately? You know, how many heart attacks have you had before? Things like that. Are you allergic to lidocaine? Might have had a change. So we're still fast. Got a short PR interval, wide QRS, and a prolonged QT. Anybody see any Q waves? What medications do we not want to give them with this? They don't get no Zofran, it prolongs QT intervals. Okay. They don't get no amiodarone because it prolongs QT intervals. Do you see anything right there that needs to be addressed right away?
Give some calcium.
Could give them calcium. What about magnesium? Got a prolonged QT interval. You give them mag. If they're hyperkalemic, they're probably gonna need some mag too. Because their potassium levels and their magnesium levels correlate. If their potassium's low and their magnesium's low, you can give them all the potassium in the world. It ain't gonna change nothing. You fix their magnesium level. Okay. Hey, you took my quarter away. Is it regular?
A flutter.
What?
It was a flutter right there.
It's a flutter with a 3-to-1.
The first one is a flutter, a fifth.
Huh? It's the same one.
Oh.
It's just the layout.
Oh.
Don't worry.
Oh, my glasses.
It was probably where it come out of my pocket and was rolled up, and I tried to tape it down or something to get it to look right. That is a flutter with a 3-to-1.
And a fistula block.
The what?
And a hemi block.
Yeah. What, is that 98 or 99?
99.
99? Is it regular?
Yeah,
don't
it's
see
regular.
I don't see any P waves.
You don't see any P waves.
Are those P waves inverted?
They're there, they're just really, really small.
Could it be AFib? Could it be regularly irregular?
Yeah.
It's not irregularly irregular. Okay.
So,
See this?
so.
Yeah.
What's that? Is that a JOA? There's some chest pain.
That's
Could be
abnormal.
vasospastic angina. And it would be controlled here, right? It would be a controlled AFib.
Also have a right bundle, right? Or did you already say that?
You just did.
Oh.
So AFib, right bundle branch block, anterior hemi block.
So that's a bifascicular block.
Anything else?
Did we miss something?
See, that just fucked with us. It makes you feel like we're forgetting something. It's like asking the question at the engineer, is there anything you'd like to change or do?
Anything? No, I say that. No, if I say, are you sure? Are you positive? Are you sure? 100% positive. Then you probably keep looking. But I may say, sure, just make you think. Give it one last look to be sure.
That's Wellens.
That's correct. Heart rate 75, peak heart interval is 170, 108 on QRS, 40, I think the QT interval is 408, and we're at negative 40. P-waves look normal. Is QRS really wide? No. QT interval's normal. You see elevation or depression?
Depression and lead two.
You see what?
Huh?
What'd you say?
I said depression and lead two.
In lead 2? Okay.
And 3 maybe?
An inverted T wave.
I think my eyes are watering.
Over here.
Is there a big one for T wave on that one, like right there, V2 and V3?
Yeah. 5, 4, 6. And so you got some ischemia over here. Remember our reciprocal changes? We see on the front, it's affecting the back. So this right here would be concerning enough for me. Yeah. I'm gonna treat it just like I would a STEMI. That's Magata. What's almost started?
I don't think so.
No, I remember I told you about that one. P-waves?
Yes.
QRS, P-wave? Is QRS wide?
Yeah.
Narrow, okay. Is it fast?
Yeah.
It's about 130. Okay.
Do you have QAs on that one?
Q-waves?
Mm-hmm.
Right there?
Mm-hmm.
Sure enough is. What that?
Inverted T wave.
Okay. What about here?
That's what?
Deep S-wave? S1, Q3, T3? Okay. What about over here?
Well,
Pulmonary embolism.
Say it again.
Pulmonary embolism.
That's a 17-year-old right there. Thought he had pneumonia.
no, you got a big one.
Massive saddle PD. They give him thrombolytics.
Didn't end well.
They buried him 3 days later.
Here's a break if you wanna, however many you wanna go
How many have I
through.
got left?
I think I got about another 15.
It's lots. Dear God.
Now if you wanna flip over and do like the 380, 380, 380, that'd be a cool one for them.
Oh, you're talking about this
And
one.
then you can take a break.
Remember we talked about the axis? Look at this. 32,768.
Stream right, maybe.
Would you say that? Does that look like VTAC to you?
Mm-hmm.
That's because it is. But this is a heart transplant patient. That's why you get this really crazy ass.
It's like the heart just did loop-de-loops there a couple times.
There's only 360 degrees in an axis. Okay. Not negative 32,768. But yeah, that's a heart transplant patient. It was a VTAC.
You did a couple of 12 leads. That's 12 lead 4 on there.
Yeah.
Oh, that was
I was trying to do telemetry.
was that pre operation or post?
Post. Oh, shit. Lock. See here. Once you cannot give a patient that is had a heart transplant, you can't give them atropine because it ain't gonna work. You can't reattach the vagus nerve. So whenever you disconnect that, that's why you get this crazy reading. And they're all the same. If you notice on these other EKGs, see that's 77, 45, and 18 or something crazy. Well, They're all the same. That's why. I've actually got 3 heart transplant patients that I've transported, and every one of them have an EKG, and they all read this. It's really wild.
But not all of them have been in meantime.
One of them is actually having a STEMI. Like, dude, there's something about your genes that.
Start saying, if you got
Yeah.
if you got try again, your second chance, and you already fucking.
What's the first one?
That
No, that one is. That's a second degree type 2. You got more P-ways, curious complexes. Hard block. Got a little Q-wave here. PSC. Here's a bigeminy. This is actually a head bleed.
There's 2 ways of saying.
Bunch of inverted T-waves.
No, is that just cardiac strain over there? 5 and 6?
That's a PVC. There's yeah. Actually, an anterior lateral. I'm sorry, anterior septal. Oh shit, I must have been drunk. There's a figuration, a figuration, a figuration. Must have been a septal. Septal wall of mine. Remember what I told you about before? Yeah. Then Q-wave, inverted T-wave. That's fine. See pathological Q-waves. Oh, yeah. Ah. See here? That's ventilation. You got a Q-wave there. Q-wave. Some irritability here.
Appreciate it. All right, so that wraps up the cardiology review, 12 leads, 15 leads. Before we take a break, what we're going to do is take a break. We'll get organized as far as doing station practice this afternoon. Up until 6, we'll work on 3, maybe 4, depending on people and instructors station. Luckily, Roger was able to come do this today. I think from all the questions, discussions, that kind of thing, y'all enjoyed it, which I thought you might. So I've been hounding him for a while to try to get one of these classes, do some of the in-depth stuff with you that he's really good at on 12, 15 leads. Like I said before, I ship him stuff. Well, what am I looking at? And he says it's me, and I go, yeah, I started playing. been a lot of questions about the Zoom recording, getting access to it, that kind of thing to review, because I know it's a lot of information at once, and a lot of people do like going back and looking over the stuff that's on there and really, listening while you have time to look at the waveforms and the EKGs, that kind of thing. And then, notice which is fine, a lot of you taking pictures of slides, that kind of thing to review through the class. No problem with that. I'll talk to Glenn about once he gets this uploaded off of Zoom and onto his, I think he uses a YouTube channel, getting y'all access in and out so you can look and review the presentation as you need to. What I will tell you is, please, for all of our sake, don't copy, reuse, send out the presentation. Keep it for yourself, keep it for your personal use. Don't, recycle into your own training classes, that kind of thing, because the material obviously Roger has copyrights to all of it, but then quite a bit of it is from the book he mentioned earlier that, would be a copyright issue, as well as there's a few of the drawings in there that are not even out yet that are part of the articles he wrote for EMS World. So, one is in that magazine that was floating around earlier on cocaine use. The STEMI Mimics section in the presentation is coming out in the magazine next month. So some of that even, EMS World owns copyrights too. So definitely no problem with using it for personal use, but please, keep it at that so that also future classes, Roger will be willing to bring back more stuff and more collections of EKGs, and people can benefit as well. Other than that, I'm just gonna.
When will you have an answer or no if it's up on YouTube where we can review?
I know it will be on YouTube, but assuming, nothing happens with the recording, it's kind of when Glenn's schedule fits to, let it download off of the iCloud bit that this records to, and then repost it on the YouTube channel. So it'll be there. He just needs to email out and give you the access to that channel. But I'll mention for him to do that and hopefully just send it out as an email to the whole class, because everybody seems to be interested. So, and then you'll have it if you need access. Shouldn't be a question of if it's done. It's just, it may take a week or so. I don't know what his class schedule, travel schedule is this week.
Thank you for your time, sir.
Being happy with the people I drag in here, because, each has a group for. That's good. So let's take about 15 minutes. Come back here at 3:30. We'll divide up and go from there for station.
Hey, Corey.
Yeah.
Hey, Corey, this is Sandy.
Yeah.
Hey, do we need to stay on, or can we knock off Zoom while y'all are doing the stations?
Y'all can knock off, because the stations will be divided across different rooms.
Roger that. Thank you. Appreciate it.
No problem.
Corey, tell Roger we enjoyed it, man.
He heard you.
Okay. Thank you.
Thank you for listening.